Buddy. I'm Paul Landesman from the Health Connector, and before I begin, I do understand that you might not be able to hear very well because we actually have an air conditioning vent just above us. So I do apologize in advance, but the people with the fans couldn't get here on time, so we have to use the air conditioning. I'm going to talk about, as you can see, from now for about half an hour to look at consumer support and the various types of consumer support that are out there working along with you. And as you can see on page 2 of the agenda, we'll look at an overview. And Nick actually talked a lot about what your role is, the certified application counselors, and I'll just touch a little bit more on that. We'll look at the navigators, the outreach partners, brokers, customer service, the public information unit, the PIU.
Hello? Paul?
Yes, can you hear me now?
Yes.
Okay. All right, so basically, as I was going through the agenda, we'll be discussing the role of the PIU, the Public Information Unit. There'll be some example questions for in terms of dealing with individuals and families, which will be the focus of working with the Certified Application Counselors' work. And then also, the last bullet talks about assessment, summary, and resources. The assessment questions are there. We're not going to go through them for the sake of time here, but you as the trainers can go back and work with your fellow certified application counselors to, when you train them, to use them as part of your review process for them. And I will discuss the resources because there's some very important information there. So basically, slide 3 just talks about the learning objectives, what we're going to do today, providing a high-level overview of the different stakeholders that are available to provide consumer support and assistance with both health and dental enrollment, describe the types of stakeholders that are going to be providing consumer support, and compare the level of support that each of the different stakeholder groups, which are the different types of consumer support, can provide for consumers, which leads us really into slide 4, which is a description. It's an overview of the different stakeholders on the left side. You can see them: the navigator, the certified application counselor, outreach partner, broker, customer service, and the PIU, and the description for each. And I just really would like to highlight the difference between a navigator, or what a navigator will be doing, and a certified application counselor. Nick already mentioned what a certified application counselor will be doing. Navigators are organizations and people within those organizations that are certified by the Health Connector to help individuals, families, and small groups prepare electronic and paper applications to determine eligibility and to assist with enrollment for coverage through the marketplace. They also provide outreach and education about the marketplace. And that's really one of the big differences. Navigators are, again, it's also mandated by the ACA and also part of the agreement that they've signed with the Connector to provide outreach and education, a minimum amount of activities per month that they have to take part in and report back to us. Whereas certified application counselors, as you know, you provide assistance with health and dental plan enrollment for individuals and families. CACs, or certified application counselors, are trained and certified by the Connector, but you do not perform outreach activities. It's not part of your requirements. The outreach partners are organizations that are selected by the Connector to assist with outbound communications and to educate individuals, families, and small groups on health insurance options. They do not perform enrollments. You may be familiar with the role of brokers. They primarily support small group or employers in selecting, enrolling, and managing health insurance plans for their clients. They also have the capability of working with individuals and families. You're familiar with customer service representatives. Both Mass Health and the Connector have customer service centers. They have the sufficient capacity and training to provide all levels of consumer support to non-group and small group. And they also provide shopping, eligibility, enrollment, payment, and account management support to to the consumers who do call them. And that, lastly but not least, our public information unit. This is something that the Health Connector had in place back in 2006. I'm dating myself. 2006, 2007, when it was formed. And this is basically We found it very, very helpful in managing when there's a lot of change, just having a point person or a team that manages policy-driven education and inquiries that are related to the ACA and the Health Connector. And if you've been to any of the MTS in the last few months, you might have met Joe Rich, who we brought on to be a part of our public information unit. And he works with Nina Dubison, who also has been an ongoing member of our public information unit here as well. So as you can see, we have a multi-pronged approach to consumer support throughout the Commonwealth of Massachusetts. On slide 5, you see a more detailed description from what Nick gave you of the role of the certified application counselors. If you want, I can call you CACs, or if you don't want, I can say the long term, but I won't use the acronym. Basically, your target audience are individuals and families. And examples of certified application counselors, as you probably are aware, are community health center enrollment staff, hospital enrollment members, and consumer nonprofit organization employees. The funding for certified application counselors do not receive funding from the Health Connector to perform this service. Otherwise, the description is as we mentioned before and as Nick said also. Navigators, briefly, again, I'm not going to go into too much detail. Just the description on slide 6 is, as we said, so basically the navigators are no wrong door, and again, that's ACA mandate. They should perform. Anyone that walks in the door, the navigator should be able to assist, whether they're an individual, a family, or a small group. So their training is a little bit more extensive because they have to be ready to help anybody that calls them, that connects with them in some way. Navigators, as you see in the note in the description on page 6 there, the law states navigators cannot recommend plans. So they can assist, they can help people look but they cannot make decisions for people, for the consumer. In our first year, the focus will be on assisting individuals and families, and in some cases, small groups who will experience changes in their coverage options. For example, we have existing Commonwealth Care, Mass Health, Medical Security Plan, and Health Safety Net members that may be transitioning into new affordable coverage options. Again, people whose plans will be changing are getting noticed. They're getting notices. So just as a certified application counselor, be aware that you may be contacted by people that may have received a notice or a letter from an agency, Mass Health, from the connector saying something's changing, so they might not really understand, or they may understand, and they may be seeking your guidance or your assistance with that. We're also focusing this first year on populations that are newly eligible for individual and small group healthcare tax credits and other subsidies, as well as the non-subsidized population. So examples, again, we've selected 10 navigator organizations, and I'll go into a little bit more detail in the next slide, so you can see on slide 7 for the full list. And also note the funding that navigators are not eligible to receive commission. They are funded through state grants that are administered by the Health Connector. If you go on to slide 7, here's the list of the 10 navigator organizations and a map that shows the general coverage of the general geographic coverage that each of those navigator organizations covers. And just so you know, there was a very thorough and complex grant application process that we went through at the Connector with Mass Health, and we awarded $1.1 million in grants to 10 different organizations that cover 10 different geographic locations across the Commonwealth. But these, you might look at that map and say, well, I see some white space there, and yes, you might see some white space, but again, because there's no wrong door, someone from an area that's near one of the navigators can actually call them and assist them. So it's not like there is no coverage in terms of navigators. Navigators are ready to work with anybody that contacts them. Moving on to outreach partners. These actually will be assisting us by providing public education communications to individuals, families, and small groups about the ACA benefits. An example of this is Healthcare for All. This group, these partners are selected by the Health Connector to assist with grassroots public education, which basically not only not only supports them, but it actually complements the education activities that are going on, as you know, with the MTS, with other outreach and education programs that the navigators are doing as well. So they will provide geographic outreach in areas where navigators are not located, but will have information on the nearest navigator, as well as possibly the nearest certified application counselor. But again, many people in the areas may already know who their nearest certified application counselor is already. So we're lucky we're in a state where there's a fairly high level of understanding of the resources that are out there. In terms of funding for outreach partners, these are funded through the Health Connectors Establishment Grant. Brokers, on slide 9, you may be familiar with. Again, they largely support small groups, which is up to and including 50 employees, to help them to enroll in health and dental coverage. For a list of brokers, you could go on the list. The Massachusetts Division of Insurance, the DOI, has a list of all brokers and brokerage firms that are registered with the connector. And their target audience is primarily businesses, but they do have the capability to work with individuals and families. And we work with the business development team here at the connector, who work with the brokers, and we meaning the staff here at the connector, also provide training for the brokers on the different areas of ACA and navigators, CAC, as well. And again, just a note in terms of the funding for brokers, as you can see at the bottom of slide 9, when they're selling health or dental insurance outside of the connector, brokers are paid on commission based upon the sale of the health and or dental insurance product. When they're selling either of those products within the health connector pays them a per subscriber per month commission. So that's just how it's broken out for brokers. The customer service, I believe you understand, they're really the front line for consumer question or issues and are trained to handle most inquiries. The examples, again, of who would be contacting them would be Health Connector employees or contractors. Sorry, these would be the customer service people who would be calling them, general public. Let me just say that a navigator would not be calling them because navigators should have the answers. So there, as navigators and certified application counselors are as frontline in terms of consumer questions or issues, which you, as certified application counselors or as in your current positions, you may already be doing that, or you and your people may already be doing this as well. Serving, you're trained to handle almost all needs. But the CSRs under the ACA, you'll also help refer consumers to other assistance groups such as navigators or the certified application counselors as needed. So the customer service reps will also have sufficient capacity and capability and the training to provide a lot of support to both non-group and small group marketplace populations. And again, they'll be able to provide eligibility, shopping, enrollment, payment, and account management support to customers. So yes, if a consumer calls up and wants help from a customer service rep to help them with their enrollment, they should be able to do that. That's something that might be different from today. Moving on to slide 11, the public information unit, as we talked about, their target audience would be the public, which could be individuals, families, small groups, the legislature, other state offices, and federal agencies that are looking for information or they have inquiries regarding education and information related to healthcare reform, the connector, the ACA, and again, as I mentioned earlier, it's healthcare staff. And members can, if someone wants to contact the public information unit, they would just call the Health Connector's phone number, the 1-877-MA-ENROLL. As you can see there on slide 11, it's 1-877-623-6765, and select the option to talk to the PIU. Moving on to on slide 12, where we're talking about assisting individuals and families, some example questions. And basically, we're looking at what is each stakeholder's role in assisting individuals and families. I've mentioned this already. Brokers, as we said, this is slide 13, brokers can provide answers to general questions for individuals and families, but primarily serve small groups and small businesses. Navigators and certified application counselors can answer most questions to assist individuals and families, with general, shopping, enrollment, and account management questions. The outreach partners, again, are trained to assist with communications and provide answers to general, eligibility, and some account management questions, but cannot provide enrollment support. So they would, again, they could refer someone to a navigator or a certified application counselor for further assistance. Customer support reps, they can answer most questions related to the individual and or the family's experience in the connector. And the public information unit can answer general questions, policy questions, and questions about the Affordable Care Act and how it affects individuals and families. The following slides are basically, you see their tables, that's slides 14, 15, 16, and 17. They basically go into more detailed questions and which of those stakeholders would be able to answer questions. For example, you can see on slide 14, the first general question, if someone has a general question, what's the QHP, what's the premium tax credit, you can see that every one of our consumer support stakeholders should be able to answer that question. It's pretty much, you can see across the board that if, in terms of general questions, everyone should be able to answer all the questions. There is one you see, the third from the bottom, about ID card status. Where's my card? Where's my family's card? Right now, that's really a broker question, but after January 1st, all the other, and again, there'll be more supporting information. As Howard said, we have your back. We've got you covered. There'll be more guidance after January 1st. There'll be more specific information on that. The next slide, 15, talks about eligibility questions. Who would be able to, for example, if someone has a subsidy question, what subsidies am I eligible to receive? Well, basically, you can see that CACs, navigators, outreach partners, and customer service should be able to assist with those. And basically, a navigator would be able to, and a customer service, because they can actually go in and assist the person, and they can see when they're in the marketplace online, going through the eligibility and enrollment process, the information would be displayed in that. So that's where that information would be available to someone who is assisting a person. In terms of application and plan management questions, slide 16, again, pretty much, if you look at the first question, selecting a health insurance plan, what plan options are available to me and my family. Again, anyone that will be assisting an individual or family within the system, such as a broker, a certified application counselor, a navigator, or customer service, will be able to see the plan options that are available when they're going through the process online. If someone has a question about how do I change my PCP that I previously selected, again, a broker, customer service should be able to help them with that. Again, these are just some generic questions that we've developed, and then you can go in more detail with your colleagues back in your offices. And on the last slide, where we're looking at account management or administrative questions, again, a little bit more specific. If someone needs help with the online process, how do I browse through the website? Again, it could be a certified application counselor, a navigator, customer service, or the public information unit. A very general question. How do I get to the website, and what do I need to do first in order to get the process rolling? If someone has a question about changing address, how to change their address, again, they can go to someone for assistance. They will be able to do it themselves, provided they would have set up an account. And again, so anyone that has access, for example, a certified application counselor, navigator, customer service, the public information unit, or outreach partner would be able to assist them with giving people that answer to those questions. And the same thing for, how do I pay online? What's the process? Those same stakeholder groups would be able to assist an individual with those questions. Policy questions, as you can see, if there's policy questions, again, that would be, you would direct those to customer service or the public information unit, because as we mentioned, public information unit is focusing more on policy. They've got their pulse on policy questions, because as you understand, policies being updated, refreshed basically every day on a day-to-day basis as we're speaking. And you know that once there's updates, we will get that information to you, whether you're a navigator, a certified application counselor, or whomever. We want to make sure that you have the most up-to-date information as we have it. And on slide 18, basically, this last slide talks, well, not the last slide, but it says, when should Health Connector stakeholders refer questions? And we've kind of already talked about this, too, is that any of these consumer support groups should transfer non-group questions, that's individual or family questions. If someone's got a policy or an ACA-specific question, they would refer them to the Public Information Unit. Any additional questions that a certified application counselor, navigator, or broker, if they cannot answer, they would refer to customer service. Again, customer service, the front line, they would also have the most up-to-date information. The next few pages are the assessment, and again, we're not going to go through them now because I can't see you when you raise your hand to answer the questions, and you're all on mute. You can tell I used to be a teacher. And basically, I just want to refer you to slide 24 and slide 25. Slide 24, if you are not already familiar with these online resources, these are some we have mahealthconnector.org is the Mass Health Connector website, as you're probably already familiar with. Healthcare.gov is the official federal consumer site for the marketplace. Has an incredible amount of consumer-friendly material that are very easy and to understand, well written, and can be printed out and used for the general public. It's very, very, I use it a lot, and I know some of the Navigator organizations are also using some of the materials they found on there because, again, as you know, in Massachusetts, we're in a little bit of a different situation than other states, but there's some pretty generic, some good generic information about the ACA, what does it mean. We also have, from the Health Connector, we've come up with some other consumer support materials that are available through our website. You can also see that on the resources we have a social media site on Facebook, so you can friend us on Facebook. And if you want to tweet with us, you can see our Twitter link right there. I don't tweet, so I just talk. And last but not least, very important on slide 25, when you don't know where to go to, where to call, and you don't need to call Howard or somebody else, just whoever, you know a name and you're like, oh, I'm going to call them. This is something that the hours, the website, the phone numbers of where to contact, who to contact, where to, addresses for mailing in things if you have general inquiries, premium payments if you need to mail them in-person servicing locations, the connector. Our customer service, we have 2 walk-in, in-person servicing locations, one in Boston and one in Worcester. We will. And again, this information is really, really important for you and for anyone in your organizations that you're going to be going back to train. Because there's so much information, there's a lot that's going on, and just to make it easier for all of you, I take this and have it up in your cube, in your office wall, so if you've got a question, you know where to go to. And that basically wraps up my portion on the consumer support.
Good morning, everyone. This is Nikki Conti from the Health Connector. I'm going to give Paul a moment to breathe. You'll notice that our next segment, eligibility and enrollment, is scheduled for about an hour and 15 minutes. So we all can appreciate this is quite a bit of information. So what Paul and I are intending to do is step through the highlights for about 1 hour and then try to leave about 15 minutes for questions. So we really appreciate your attention to all the details in this presentation. So I'm going to start right on slide 3 of this presentation. So there are some major concepts that are going to be covered and we want you to feel comfortable with. So we want you to feel comfortable with understanding how eligibility is determined. We want you to feel comfortable with describing the criteria used to determine individual and family eligibility. We're going to review key dates for enrollment. We're also going to step through the enrollment processes for individuals and families for non-group products and describe the processes for billing and payment in non-group products. So moving to slide 5, I think one of the callers before I'd ask this question, what is non-group coverage? I think for folks who are familiar with working with Mass Health members as well as Commonwealth Care members, we're not used to that term non-group. But I think, it's important to just note that, the world's shifting, things are changing. At the Health Connector, you know that we're going to be selling, we're offering qualified health plans. So in the past, we had offered Commonwealth Care plans and Commonwealth Choice plans, but now, we're kind of thinking about our world in a non-group and small group, kind of non-group and small group buckets. So we'll try to keep the lingo to a minimum. We're just talking about individuals and families. So on slide 7, I think folks are pretty familiar with this process, but I think there are going to be a couple of important things here to note. Basically, what this chart is showing you is, each of the steps that a consumer is going to need to take before they can become enrolled in a health insurance plan. So first and foremost, we need to establish eligibility, and then consumers need to shop and compare plans. They need to submit some enrollment information, submit terms and conditions, and then submit payment. For our Health Connector members, this submitting payment piece is incredibly important, so I just want to put that in the back of your mind. During this presentation, we're going to go through each of these segments in much greater detail, but as you're training your staff, I think this might be a good visual that you might want to print out, have them pin up at their desk, because it really gives them a nice little, a nice reference. If you go on to slide 8, this is labeled enrollment for transitioning members. So I think you've heard us say over and over again that we have several individuals in Massachusetts who are transitioning. Specifically here at the Connector, we're transitioning our Commonwealth Care members as well as our Commonwealth Choice members. And individuals and families who are in subsidized insurance coverage, as you know, are going to require transition into a Health Connector QHP, and there are some very key dates here, or else they're going to risk losing their coverage. December 23rd. I know you've heard us say this before, but I just want to kind of put that date in the back of everyone's mind. That December 23rd date is the date in which individuals and families who are trying to enroll in the January coverage should have applied, enrolled, and actually made their payment by that date. There are other consumers at the Health Connector, such as individuals, families, and employees in our commercial coverage, our Commonwealth Choice, our Business Express, or our Young Adult plans, who also must transition. There are all sorts of things that these folks need to do. The paths that these folks need to take are very similar, and the date for a number of them are the same. So again, some key things to keep in mind. Commonwealth Care is ending on December 31st. Our Young Adult program is ending on December 31st. Our Commonwealth Choice program, I'm going to say this again later, but just going to hear me like repeating things over and over again. Commonwealth Choice will be ending by March 31st. For our individuals and families. Other Business Express programs are going to run throughout the 2014 calendar year. So you'll see that in other slides, but just want you to hear it again. Let's move on to slide 10. So I think some of you are familiar with this information, but it's always, I think this is laid out a little bit differently and will be helpful for you as you explain it to other folks within your organization. So what is non-group eligibility? So for those who are seeking health insurance through mahealthconnector.org, whether they're seeking non-subsidized or subsidized, there are a couple of key pieces of information that we need to verify. This is the same for Health Connectors, this is the same for Mass Health. First, we need to confirm that the individual is a U.S. citizen, national, or non-citizen lawfully present in the U.S. We need to know that the person is a resident of the Commonwealth of Mass he or she intends to reside in Massachusetts, and we also need to confirm that the person is not incarcerated. Now, there's an important note here about Indian status. So, verified Indian status is not an eligibility requirement, but it does entitle individuals to additional cost-sharing reductions in special enrollment periods. In a few slides, we're going to dedicate some time just looking at American Indians, but I think it's important to note up front when someone is shopping that if they are in fact, do in fact have Indian status, they may be eligible for additional cost-sharing reductions and are not subject to the limited enrollment period. Now, if somebody is seeking subsidized coverage, there are some other eligibility criteria. They need to have a household income of less than or equal to 400% of the federal poverty level, and they may be eligible for subsidized health insurance if the applicant meets income requirements and is not eligible for certain minimum essential coverage. And we are going to get into that in greater detail. If you look at the chart on slide 11, I think this chart does a really good job of showing you some of the information that we've been presenting over time. Now, what we're looking at here, from the Health Connector perspective only, really, is we're looking at the income levels from 0 to 400% of FPL. So again, individuals who are within that income bracket could come in and be eligible for a QHP. However, individuals with incomes from 0 to 133, the only folks who are eligible within that income bracket are lawfully present immigrants, okay, for Health Connector QHPs. Above that income bracket, individuals may be eligible for federal cost-sharing reductions, as well as state premium and cost-sharing subsidies up to 300% of the federal poverty level. These are going to be rolled into our connector care plans. Again, individuals up to 300% of the FPL, connector care. Then there's the bracket between 3 to 400%. These are folks who in the past, those folks really in that income level weren't necessarily known to us. So there is an opportunity here to get additional folks enrolled with some subsidies that hadn't had subsidies before. So I'm going to move along to slide 12. And I think slide 12 more or less says everything I just said, but we'll look at that again and just make sure we don't have anything missing here. When you are teaching this back to your folks, I think what is important to note on slide 12 is that the connector care plans, and actually this is a really important point to make, and again we'll probably be repeating it a few times today. Connector care plans are going to be funded by premium tax credits and cost-sharing reductions, as well as additional state subsidies. So similar to Commonwealth Care, there are 3 types of connector care plans. Plan type 1, 2, and 3, and you can see the income thresholds associated with each type. These plans are also detailed in the appendix, and we can take a look at that. But it's important to know that if somebody wants to receive federal cost-sharing subsidies and state subsidies within that income level, they need to enroll in a connector care plan. For individuals, eligible Mass residents may qualify for premium tax credits, which is first applied to qualified health plans, and then any remaining amount of the pediatric portion of the qualified dental plan. And we'll talk a little bit more about dental plans as well. So I'd like to move your attention to slide 13. I think someone had asked the question, if not today, in another presentation, how are connector care plans put together? How are these subsidies calculated? So I think a really easy way to think about this is that there are really 3 parts to the connector care plans. There are the federal subsidies, there are the state subsidies, and then there's the member contribution, the amount that the member is going to need to pay towards their premium. So the method in which the premium tax credit is determined is explained here. as well as state subsidy. And we're going to go through this on other slides, but I really want a couple of things on this. One is we will go through the examples, but I don't want to cause any panic for people. I want you to remember that the system is going to be calculating this. They're not going to be required to sit with members and do the math calculation. But I think it's important for you to know that this connector care premium or this connector care plan is made up of these different pieces. And when an individual is going through the experience and they see the rates returned for the connector care plan, those rates are based on the individual selecting the maximum premium tax credit that's available to them. So we're going to stress that. I'm going to stress that. Paul's going to stress that, and then our other colleagues will be talking about that this afternoon when they talk more about our connector care plans. But I just want you to make note of that. Also down the bottom, income eligibility is determined by the applicant's MAGI. And we have staff here who are going to talk to you and answer some questions about modified adjusted gross income. So we have them here as well. So let's move on to slide 14. I wanted to take a look at this chart with you just so you can get a sense of the premium targets, the subsidized coverage. So you have, similar to how Commonwealth Care is broken out today, this chart explains connector care in a similar way, but also explains the tax credits as well as the premium that the member would be responsible for. So in the middle row, you're seeing the maximum tax credit that the person within the income level would be eligible for. And then in the last row, you're seeing the connector care plans, the lowest cost plans available within that bracket. Something to note here is that the connector care member contribution does not vary by age within a region of Massachusetts. Okay. So the note, each region will have its own member premium payment schedule. Plan availability will also vary at the zip code level, and this will affect the member's contribution schedule. So similar, but slightly different than today. All right. So I know Paul and I said we weren't going to go through examples just because we do have a lot of things to cover, but I want to bring your attention, if you could, in your books, check off example 15, 16, 15, 16, and 17. This is going to be really helpful when you are talking to staff in your organization. We took a fairly simple example. We took John, who is single, 24, with an income of $22,980, and his FPL is 200%. So what we did is we break down how what his premium tax credit is, what his connector care plan might cost. If John went a different route, what would that look like for him? And this is something that folks had asked just so you could spend a little bit more time kind of figuring out how this could work in real life. On slide 18, the premium tax credit, let's look at the column on the left for a moment. I think it's really important that you feel comfortable with this. So premium tax credits, again, who is eligible? So eligible Mass residents earning equal to or less than 400% of FPL may qualify for federal premium tax credit. Enrollees must select a qualified health plan through the Health Connector and not be eligible or enrolled in other qualifying minimum essential coverage, and we'll cover this. And then there are some notes here that are important to note. Native Americans, Alaskan Indians with incomes greater than 300 do not pay any point of service cost sharing for services received at Indian Health Services Center. And then all premium tax credits provided to all individuals and families are first applied to the qualified health plan, and then the remaining portion is applied to the pediatric portion of the qualified dental plan. That is a mouthful. Just know, up to 400% of FPL, folks could be eligible for tax credit. our connector care folks, that is up to 300 of FPL. In order for them to be able to take advantage of that lowest cost, they need to take their maximum premium tax credit. I think that's more for you to, that's important for you to know. If the rest of this is really for your reference on 18. On slide 19, this this slide talks about the health safety net. So HSN, and folks know this also is free care. It is not going away. It's going to be administered by Mass Health, and it's going to cover certain qualified QHP eligible individuals and families who meet income and eligibility rules and who are pending enrollment in a Health Connector plan. So I want to leave mark that slide off as well. You want to take a look at that slide. And apologies for going so quickly, but there is quite a lot of detail here. We want to take your questions. On slide 20, I mentioned that I would spend more time on American Indians and Alaskan Natives.
There's so many of them.
So let's look at this, and I'm going to read this back to you. So what's the eligibility and, special enrollment? So there are some special provisions for eligibility, enrollment, and cost sharing. So an Indian is defined as a person who has either been verified as having Indian status or is attested to being an Indian and is awaiting verification of Indian status. Determination for special treatment for American Indians, Alaska Natives, regarding enrollment and cost sharing must be made regardless of whether the applicant requests such a determination. An American Indian, Alaska Native must meet all other eligibility criteria and must also meet enrollment criteria. And an American Indian, Alaska Native may enroll in a QHP or change from one QHP to another one time per month. This is different than other folks, so you may want to mark that off. For Indians who are enrolled in any non-group product through the Health Connector at any metallic tier and have a household income of less than or equal to 300%, all members' cost sharing is eliminated. And this elimination of cost sharing also applies to services, items, or referrals by the Indian Health Services for Indians who have household magi of any amount. And we have an appendix in the back of this module that talks about where all the Indian Health Service centers are in Massachusetts. So on slide 21, just curious. I don't really need an answer, but...
They do have an ID card. I've seen an ID card.
Okay, so there's...
There is an Indian ID card.
Hello?
Hi, folks. I think we can hear you.
Yes.
And I'm glad that there's a lot of conversation about the American Indian ID cards. Would you mind putting the phone on mute for the others? Thank you. Okay, so I just want to talk a little bit about the catastrophic plan and eligibility. So this is something new, something a little bit different for folks. On slide 21, if an individual is eligible for enrollment in a catastrophic plan, if he or she either has not attained age 30 before the beginning of the year or is 30 years old or older when the plan year begins and has a certificate of exemption based on financial hardship or a lack of affordable coverage, meets the criteria for eligibility to purchase individual non-group plans, and is at any income level. Special to note here, if enrolling in an individual plan during a closed enrollment period, an individual must meet the special conditions to enroll outside of the annual open enrollment period. And I just want to note that we have an appendix at the back here that talks about special conditions and more specifically the triggering events. And there are a few other points here about individuals enrolled in a catastrophic plan who turn 30, as well as when someone can purchase. So I think this is another one to come back to read through. But catastrophic plans are something new for the Health Connector. And the very last point is important for you to have in the back of your mind. Individuals purchasing catastrophic coverage are not eligible for premium tax credits, federal cost sharing, or state subsidies. So these catastrophic plans typically are of lower cost. So we just want you to be aware of these. They are available, but they do not, will not, you cannot apply tax credits and federal cost sharing to these. On slide 22, these are all of the eligibility verification criteria for non-group. Again, whether someone is seeking coverage through the Health Connector or Mass Health, as well as I wanted to have you look at slide 23. Okay, so I think folks are fairly comfortable with the information or have seen the information that's on slide 22, but I want to bring your attention to slide 23. This may be something that we haven't spent a lot of time on in the past. So what is minimum essential coverage? So minimum essential coverage is the minimum standard of coverage to comply with the ACA's and the individual mandate. To be eligible for a non-group subsidized coverage, enrollees must not have access to minimum essential coverage. Access to MEC will prevent an applicant from receiving federal and state assistance, and access to MEC can be defined in two ways. One, for certain types of coverage, just being eligible can block an applicant from receiving a subsidy, and two, for other types of coverage, enrollment is required to block an applicant from receiving a subsidy. So, for example, if you look to the left, eligibility for these types of MEC can block an applicant. So, Medicaid coverage, Medicare coverage, including Medicare Advantage. And then to the right, enrollment in these types of MEC can block an applicant from receiving a subsidy. So certain types of veterans health coverage, and then coverage purchased in the individual market. Another piece that you might want to have your staff photocopy and hang up. All right. So on slide 24, when someone is submitting their eligibility, well, someone may need to submit eligibility verification documentation. So if someone applies and then the system indicates that an individual or family is not eligible for state or federal support, the person or the individual or family is provisionally eligible if he or she attests to meeting the eligibility criteria. So this is really important. This is something very new. So the individual or family will receive a letter that requests information needed to verify that they are eligible for state or federal support, and there's also a deadline to submit these documents. So they have 90 days to provide documentation, during which time they're going to be eligible based on the attestation. So there is required verifications for both non-subsidized and subsidized coverage, and they're all going to be sent to one location. So that address is here. And then if after the 90 days, if we're unable to verify the attestation, the individual or family's eligibility, if after the 90 days we're unable to verify the attestation, that person or that group's eligibility is going to be determined based on the information we have. Okay.
Yeah.
I was pausing for reaction in the room. Okay. So on slide 25, this is a term, you won't be quizzed, but we just want you to feel comfortable with these phrases, concepts. So rating factors. Rating factors are qualities associated with an individual, family, or an employer group, such as age and zip code. These are used to determine the premium cost of a specific health insurance plan. So just something for you to know, non-group or plans for individuals and families, those rates are calculated on a per member basis, and the non-group per member rating factors are geographic area and age. So I am going to skip over the assessment questions and hand this over to my colleague, Paul Anderson.
Hi, everybody. We're going to actually move on to slide 34. So yes, there's quite a number of assessment questions that you'll be able to work with your trainers and trainees back at your respective organizations. But I'd like to move on to the next section that we'd like to cover is open enrollment or special enrollment periods. And moving on to slide 35, what is open enrollment? Again, this is something you are probably already aware of, but I think we need to remember that the federal open enrollment period begins October 1st of this year and runs for 6 months until March 31st of 2014. Note that, again, on slide 35 there, that note that after the 2013 to 2014 enrollment period, the state and federal open enrollment periods will be aligned and will run from October 15th to December 7th, starting in 2014, for an effective date of coverage beginning on January 1st of the following year. So basically, if you've been to the MTFs over the past few months, we've talked about the different enrollment periods going on, and this is basically the last, well, not the last one, but we have this one extended one now for the 6-month period, and then we will be then in line with going forward in 2014, October 15th to December 7th for the following year. So you're probably already familiar with this, you've probably heard about it, you're probably already working with it. Just note that, as Nikki mentioned, there are exceptions known as triggering events, which allow individuals or families to shop outside of the open enrollment period, and there is information in the very extensive appendix in the back of your packet here. For small group, employers can shop year-round, and basically that's what you need to know. There's a couple points there, but just know that they're a little bit different. And then I'd like to go to looking at on the next slide, which is 36. Sorry. Right, just to look at the key dates. As we mentioned in 2013, looking at the chart, the open enrollment period for the QHPs or the qualified health plans will be October 1st to December 31st. For the effective date of coverage is January 1st, 2014. In the year 2014, from January 1st to March 31st, the effective dates will be in accordance with our coverage effective dates policy. But again, remember, as Nikki mentioned earlier, at least 5 business days before the first of the month when the coverage would begin. And we've mentioned that. It's been in some of the other slides we've talked about, and you'll probably hear it again. It's 5 business days before the first of the month for the QHP coverage. As I just mentioned also, in 2014, the open enrollment period from October 15th to December 7th for coverage that would begin January 1st of 2015, and looking even more forward, for 2015 and beyond, from October 15th to December 7th will be the open enrollments for the effective date of coverage beginning January 1st, 2016 and beyond. Note that in that box there on slide 36 that individuals and families who do not enroll in a QHP by April 1st of 2013, which is the day after open enrollment, they risk losing coverage and would then need to wait until the next open enrollment period, which would be October 15th through December 7th of 2014, for an effective date of coverage on January 1st of 2015. Yes. So what are the triggering events on slide 37? As I said, we do have information on this in the back, but this is very important. I think you might be familiar with some of these already, but again, this is the new naming conventions that are being used at the national level as well. For the non-group or the individual or family product, a triggering event is if they gain a dependent or become a dependent, such as marriage, birth, adoption, placement for foster care, or court-ordered care of child. If someone loses minimum essential coverage, which Nikki had just talked about. If someone becomes eligible for a new qualified dental plan or a qualified health plan due to a permanent move. If someone identifies as an American Indian or Alaskan Native. If someone was erroneously enrolled or not enrolled in a QDP or QHP due to an HHS or Health Connector error. If someone's enrolled in a QDP or QHP that violated a material provision of its contract, if someone becomes eligible or ineligible for premium tax credit or has a change in cost-sharing reductions, this applies to enrollees and their dependents only. If someone is enrolled in unaffordable employer-sponsored insurance, or that employer-sponsored insurance does not meet minimum value, if someone meets other exceptional circumstances, or someone becomes a lawfully present individual or citizen. So when must triggering events be reported? This is very important. They must be reported within 60 days of the event to the Health Connector. Changes to plan enrollment are effective in accordance with the enrollment in the individual or family plan, which is a non-group plan policy. For birth, adoption, or placement for adoption or foster care, coverage is the effective date of the event, and premium tax credits or the cost-sharing reductions take effect on the first day of the full month during which the individual or family is enrolled in a qualified health plan or the qualified dental plan. Again, this is important policy information for these triggering events that would be relevant for you and your colleagues to have taped on your walls of your offices or your pews. Now, submitting enrollment information. Basically, what are the QHP and QDP enrollment methods? And again, sorry for using the acronyms, but it's a lot easier and faster, and you'll be using them before you know it too. For the QHP and QDP enrollment method, you can, again, online for the qualified health plans only. You can also enroll by paper. You can mail them in person or fax, as we've mentioned earlier, as well as by phone. Again, detailed contact information, including phone numbers, hours, and addresses, are located in the appendix, as we've also already mentioned. Moving on to slide 41. When consumers are eligible to enroll in a plan, what information must they provide? Again, this is just as a reminder that this is the kind of information that they'll need to provide. For the non-group, they'll need to supply or provide eligible individuals or families, select plan name and carrier, the names of all prospective enrollees, including the dependents, the effective date, the selected PCP. Again, this would be for the qualified health plans only. And for dependents that are over 26 years old, disabled status. Again, this is for QHPs only. Now, accepting terms and conditions is moving on. Accepting terms and conditions of the application and enrollment on slide 43. You'll notice that there are three methods here. We have electronic or online submission, paper submission, phone submission. Probably, if you don't already know, the preferred method will be online. The applicant would electronically sign the enrollment forms and the terms and conditions by clicking agree on a confirmation such as I agree. Again, for the qualified health plan and also for the qualified dental plan, but note that online enrollment will not be available for the qualified dental plans on October 1st, but will be available in the coming months. Again, just as you know, there's so much going into the system to build it to be ready for October 1st, but that functionality will be coming in at a later point. But not to worry, we will be making everyone, like the navigators, the certified application counselors, all consumer support organizations will be made available of when functionality is up and running. If any of you are familiar with when MMIS went live and all the information and the communications that went out, it will be similar, if not more vibrant, more robust. Paper submissions, similar to today, the applicant will physically sign the enrollment form and the terms of conditions, and once signed, both forms are sent to the Health Connector. They can be faxed, they can be mailed, or they can be brought in person for both the qualified health plan and the qualified dental plan. Phone submissions, again, if someone's on the phone with the customer service rep or a navigator, the applicant will attest to agreement by voice, in which case the customer service rep or the navigator can complete the submission electronically, including the signatures of the enrollee and the customer service rep and or navigator. The applicant will sign and mail in a printed completed application that's generated by the customer service rep or the navigator, again, for both the qualified health and or dental plans. To submit payment, again, when and how, again, slide 45, when and how to pay their premium payments. Again, for the QHPs, the Qualified Health Plans, enrollees send their premium payments to the Health Connector. Remember the magic 3 words, 5 business days before. And that's actually in the second bullet. The Health Connector Customer Service Center processes the premium billing and payments. We must receive at least 5 business days before the end of the month for coverage the following month. The Health Connector generates the initial bill and sends to the enrollees. Again, note the 4th bullet, the enrollee can pay by check, by money order, e-pay, in person, or by mail or electronic transfer from a financial institution. The connector processes the enrollment and transmits monthly enrollment confirmation to the issuer, the insurer, and so that means the enrollee does not send the money to the insurer, you send the money to the connector, and the issuer, the insurer, the carrier, will effectuate the enrollment. They produce the member ID numbers and they generate the member packets to the enrollees. All right. So on slide 46, in terms of submitting payment, this is a reference for in case of situations where there's delinquency, termination, and reinstatement for subsidized individuals or families. What happens when a payment is submitted late and or not in full or a plan is terminated? Again, this is really for reference. If there's voluntary terminations, if there's delinquencies, in a case where there's termination for non-payment or reinstatement. I think there's just a couple of things I would like to point out, that in terms of voluntary termination, this occurs when a non-group member voluntarily terminates his or her coverage, which may occur at any time, and this termination will take place prospectively because, as you know, the member would have paid the month in advance because they would have paid at least 5 days before the end of the month. And in terms of reinstatement, again, these are for subsidized individuals and families. Again, subsidized for reinstatement, consumers must reinstate within 30 days of their termination. They can be reinstated an unlimited amount of time. That's key here. And there is no reinstatement fee for enrollees that are receiving federal or state assistance. Just a couple of highlights there, because what I want to do next on slide 47, which looks very similar but is different, because slide 47 actually covers delinquency, termination, and reinstatement for non-subsidized individuals and families. What happens when a payment is submitted? Again, the same scenario. Whether it's in terms of voluntary termination, delinquency, termination from non-payment, or reinstatement, note that in reinstatement, the differences are for non-subsidized enrollees. I'm at the bottom row there. Non-subsidized, the third bullet, non-subsidized enrollees can only be reinstated once a year, and there's a $50 reinstatement fee for non-subsidized individuals or families in small groups. So I've just pointed out the major differences between delinquency, termination, and reinstatement for subsidized and non-subsidized individuals and families. The other information is also very important, but those are the major differences, which you might end up having calls or questions about. And I believe that brings us to the end.
Hi, this is Colleen Murphy, and I'm just going to talk a little bit, although you've probably heard a lot about this already, about the modified adjusted gross income piece of eligibility determination. A lot of these slides you've probably already seen before, but given it's kind of the bedrock to eligibility determination to figure out what somebody's income is and household composition, we wanted to make sure that we went over it again to hopefully make sure everybody's comfortable with it and all the pieces included to figure out how much income somebody has and what level of the federal poverty level they fall under. So on slide 65, we started with modified adjusted gross income, MAGI. We want to make sure that everyone understands that there are two pieces to MAGI. It's a methodology that uses federal income tax rules and concepts, and it's used to determine somebody's income and count what their income is, but also determine their household composition or family size. So this is different than what we're used to today for Mass Health and ComCare income determination. We're using gross income today, but moving forward it's going to be taxable income. So federal income tax rules and concepts of adjusted gross income with some modifications. That's where the M in MAGI comes from. They're used, but it's not simply a number off the tax return. Include on slide 65, we do have the final Medicaid and CHIP rule, the regulation there, and also the section of the Internal Revenue Code that's used to determine what's taxable income and what isn't. So the next slide, slide 66, goes over what MAGI household composition is. There are some differences here between premium tax credits and mass health determination for household composition. Under MAGI, the definition of household composition is different than what it is that we know today. It's one of the biggest changes and things that's a little more unpredictable than other parts of eligibility than what we're used to. In today's world, we look at a family group to determine household composition, and it's usually, the people who live in the same house and are related to each other are considered a family group. But under MAGI, there's no longer going to be one family group, but rather each individual will have their own household determination to determine what their income eligibility is. Even though they may live together, be related, or whatever else, everyone's going to have their own individual household determination. That may be the same for everybody who lives together, but it also may be different. So if you're going to underline one section of this, I would say that last bullet is one to highlight. Generally speaking, MAGI follows the federal tax household rules to determine the household composition. For the premium tax credit, the tax household is always the household that we're looking at for eligibility determination. So that one should be pretty straightforward. And just to mention as well, people who are married must file together their federal taxes in order to be considered in the same household and get benefits. However, for mass health, we start out with the tax household. We look at those tax household rules, but then there's some exceptions that may apply based on family relationships and who actually lives together. So this is where things might change. Okay, slide 67. I wanted to highlight the mass health MAGI household composition elements. Like I mentioned in the last slide, we look to the tax filer and who they claim as dependents. We could stop there to determine the premium tax credit household, but for mass health, we then have to have a second consideration to look to see if there's any exceptions that may apply for the dependents. The main exceptions we look to is to figure out whether that dependent is claimed by someone other than a parent, whether that dependent is living with both their parents, but both parents don't file jointly. This is often the case when you have unmarried parents living together with the child. And the last exception is whether that dependent is claimed by an absent parent. If the dependent meets one of these exceptions, there's relationship rules that we apply at that point. We look to see who they're related to, who they're living with, and that's how the household composition is going to be determined. So you can see this is where it's not really as straightforward as a tax household. Just to note that married people are always included in the same household, regardless of how they file taxes or file taxes at all. And as you are all well aware, there's probably going to be a lot of people who will qualify for mass health that don't file taxes at all. And there's special rules that we'll look to for them, again, regarding how they're related to each other and who's living together. Slide 68, we go over the income piece of MAGI. We just talked about how to determine the household. Now that we know in whose household, we're going to look to see how much income there is. Just to reinforce this message, we expect that people will benefit from MAGI income counting because this isn't gross income like it is today, and people are going to be counting less income that's otherwise counted, that wouldn't otherwise be taxable, and because when you add this all up, it's going to probably come out to be a lower FPL level. We think people should be benefiting from this, so that's a good thing to reinforce. MAGI takes taxable income, the taxable adjusted gross income, to figure out what somebody's income is, and then modifies it, that's the M part in MAGI, by adding back in some things like tax-exempt interest and Social Security income. Generally speaking, the adjusted gross income is found on line 37 of the IRS Form 1040, so that's the number we're going to be looking at mainly, with a few changes. Today, there are some things that are counted that MAGI will not count. So in the future, for Mass Health, MAGI will not count child support income, any pre-tax deductions like child care expenses or health savings account, things that are taken out of someone's paycheck ahead of time, workers' comp, benefits, gifts, inheritances, anything that's not taxable is not going to be counted towards somebody's MAGI, with the exception of some of the things you mentioned before, like Social Security income and some tax exemptions, some other interests that we want to add back in. Also, MAGI allows for people to take tax deductions from their income, and you can subtract that from what would otherwise be countable income. So if you have student loan deductions, you can take that out of your MAGI, and that would, again, lower your income. So that, we think, will benefit people in the long run. And those are the two main pieces of MAGI, the household and the income counting. And now I'm just going to pass it over to Dina to go over some of these other slides that relate to MAGI as well.
Okay. I'm going to take you to kind of the next section, which talks a little bit more about data matching and electronic verifications. It's slide number 69. One of the big differences with the Affordable Care Act is that it requires us to leverage electronic data sources to verify information and to streamline the application process. And this is really good news because we're going to be kind of dropping to paper verifications as a last resort. So if we're able to find from federal or state data sources that we can verify the information that you're self-attesting, we're no longer going to ask for paper verifications. Obviously, there's an expectation that somebody who self-attests to a particular income amount, we're not going to find an exact match for that income amount from our state and federal sources. So there is a policy within the federal regulations that's called reasonable compatibility. And reasonable compatibility basically allows us to see if the numbers are close enough, meaning the number that somebody self-attests to versus the number that we get from a data source. If they're close enough, then we will accept what the person has self-attested as verified, and we will not request verifications from that person. So the next two slides, which I'll talk about, get into just a little more detail about the reasonable compatibility process. So slide number 70 kind of talks a bit about the reasonable compatibility process for premium tax credits. And just to say up front, this is a back-end systems process. So this is something that you don't have to worry about. It's going to happen on the back end. Somebody is going to self-attest to what their income is, and we're going to look in the system at state and federal sources to see if we're able to verify it. So for premium tax credits, if the income that a person self-attests to is higher than the income from an available data source, the income will automatically be considered reasonably compatible, and we will take that self-attested income amount, and that's what will be listed as verified in our eligibility system. If the claimed income is lower than the income from the available data source, then they need to be within 10% of each other. So the self-attested number and the number from the data source need to be within 10% of each other for us for premium tax credits, for somebody to be considered eligible without having to submit further paper verification. If they're not within 10% of each other, then paper verification, a VC1 request, which I'm sure many of you have seen, will continue to go out to request that information. Jump over to slide number 71. This just talks a little bit more about the Mass Health reasonable compatibility process. There are some similarities to premium tax credits, but also some differences. So for Mass Health, if the two numbers that come in, meaning the number that's self-attested and the number from the data source, are either both above or below a certain income threshold, we'll consider that to be reasonably compatible. And this kind of relates to the whole concept of coverage types, which I know is being talked about later. So for instance, if somebody self-attests that their income is 100% of the federal poverty level, but our data sources say it's 130%, we're going to consider those numbers to be reasonably compatible because we know that the person's going to be eligible for the same coverage type regardless. So we're going to put them in the same bucket, same coverage type, and say, okay, you're eligible, you're good to go. If, however, somebody claims the two numbers are not both above or both below, that's when we're going to drop to the 10% rule that's used for premium tax credits, which is that they need to be within 10% of each other, the self-attested number and the number from the data match. And if they're not within 10% of each other, then we'll drop to paper verifications. One important note, which I've kind of said throughout, is in both cases, the self-reported income amount is the amount that's verified in the system. So if something's reasonably compatible, we're going to take the number that the person self-attested, and that's actually what's going to sit in our system as a verified number. Okay, so that's kind of the concept of reasonable compatibility, which again, the goal is for us to be able to ask for less verifications as often as we can. So for slide number 72, this talks a bit about non-tax filers and what happens if there's no electronic data match. Obviously, we know there's going to be many instances, particularly for the Mass Health population who are lower income, where people either don't file taxes or we're not able to get a data match to verify income. So for Mass Health, there's no change in the income verification process. We don't have a tax return or we're not able to get a data match. We're going to send out a request for information as we do today, the VC1, and we're going to ask for that income verification amount. For premium tax credits, paper verifications can also be submitted as they are done today for Mass Health. The two important things to note, one of which Colleen mentioned earlier, is that married couples must file a joint tax return, and also that in order to receive premium tax credits, a person must file taxes for the premium year that they're receiving those premium tax credits. So if somebody's eligible in 2013 for premium tax credits, they need to make sure to file a tax return for that tax year. Slide number 73, just a little bit more detail about verifications and about how, people can still submit paper verifications as they do today, and that basically what we accept today, we're going to accept tomorrow under the Affordable Care Act. So pay stubs, Social Security letters, last year's federal tax return, pension award letters. Those same verifications that people send in now, they will continue to be able to send in the future to verify their income. The last slide just kind of provides an overview of some of the big differences. This is slide number 474. Some of the big differences between premium tax credits and Mass Health. As Colleen also mentioned earlier, premium tax credit household is always the tax household. Mass Health does have exceptions to that in certain cases. Premium tax credits do require using projected annual income, whereas Mass Health still requires using a current monthly income calculation, which is business as usual, how we do things today. The other big difference is that some income that's counted for premium tax credits is not counted for Mass Health. For instance, lump sums. Lump sum payments are counted for Mass Health in the month they're received, but they're not counted beyond that. For premium tax credits, lump sum amounts are counted. Also, American Indian and Alaska Native distributions and certain scholarships and grants are counted for premium tax credit income calculations, but not for Mass Health income calculations. So that kind of goes over our overview of MAGI. I think we're going to turn it over to either Nikki or Paul to continue. Okay, or both.
Thank you.
So thanks, everyone. We're going to jump in, and we do want to leave some time for questions, but Paul and I want to provide you with an update from the recently recorded presentation on credits and subsidies. So we're going to just highlight some of the slides, and then we want to open up the call for any questions on MAGI or credits and subsidies. So if you flip to slide 3, the objective slide, we want to go over 4 key concepts. We want to touch upon the different types of credits and subsidies available under the ACA. We want to explain eligibility rules, explain how consumers can use premium tax credits, and then explain the reconciliation process. So moving to slide 5. Just want to bring your attention to the slide. This is a graphic that folks, I believe, have seen before. It's a yellow and blue graphic. But I want to make special note that probably not every time you see this, but as we've been moving along, we've been updating this to reflect our most recent policy decisions. So just want to make a special note, the items or the blocks that you're seeing in yellow represent the Health Connector covered members, and the items in blue represent Mass Health.
And this also is another form of the, we saw a slide earlier today that it was more like a bar chart with the horizontal lines, with the FPL going out horizontally. This is it's another version of that as well.
Okay. So if you turn your attention to slide 7, we want to focus on this, because this has changed really since the last time that we had explained it to you. We just want to make sure that we're being very, very clear about our about our affordability options, and very specifically about our connector care plans. So as you know, we've talked about the federal government and the Commonwealth together being able to provide eligible individuals with premium tax credits, cost-sharing reductions, and other subsidies that can be applied towards the purchase of QHP. Remember, all of this is offered exclusively through the Health Connector. Premium tax credits. These are tax credits provided in advance, applied to a health plan's premium to reduce the cost for an individual or family, and these credits can only be applied to QHPs offered by the Health Connector. The next row down, mass premium and cost-sharing subsidies, and you'll see in parentheses the connector care plans. Again, this is different than how we have presented in the past. Policy has evolved on this. So we just want to make sure that folks understand that this is additional financial assistance to reduce the monthly premiums and out-of-pocket costs, and are applied to connector care plans made available only through us. And connector care plans are subsidized from eligible federal premium tax credits and cost-sharing reductions, as well as state subsidies. So in short, persons who are enrolled in connector care plans will be able to take advantage of federal premium tax credits, get cost-sharing reductions, and take advantage of state subsidies. So individuals up to 300% of FPL. There is no here about aliens with special status. I don't know that we've spent enough time on them today, so just want to remind folks, remember our AWSS population. Those folks are those who are lawfully present AWIS from 0 to 133 are eligible for a connector qualified health plan with a caveat. They have to be 21 plus. Other folks would be going to Medicaid. Okay. So I'd like us to move to slide 9. Slide 9 and slide 10, I just want to remind folks that this was covered earlier this morning when we talked about the eligibility criteria, but this is described a little bit differently, so this, when you're reading through the material, you might want to just hold on to these slides for your reference to explaining it to your folks. It's exactly the same, just looks a little bit different, as is slide 14. Now, going on to slide 11, someone had asked a question earlier today, really about premium tax credits, really how does it work and what can consumers do. So on slide 12, I just want to reiterate a couple of things. So typically, taxpayers have to wait until filing taxes to get tax credits. So these premium tax credits are a little bit different. So starting in 2014, these premium tax credits are available right away in advance of filing taxes. And those advance payments are actually applicable to the cost of their premium. So the taxpayer has a choice to make. They can take the tax credit in the form of advance payments. Those payments are made to the issuer or made to the health insurance carrier, the health insurance plan, to lower the monthly health plan premium. Or the taxpayer can claim the credits at the end of the tax year, similar to other tax credits. Really important for our consumers to know, for all of us to keep in mind, is that taxpayers choosing to take the tax credits will need to reconcile the payments on their tax return. Okay? So really, really important to know. On slide 12, an individual or family will apply through the mahealthconnector.org or through the HICS system to determine if they're eligible. We're going to estimate the amount of the premium tax credit that they're eligible for based on projected income. After the person shops for QHP, they'll have an opportunity to decide whether to take the full amount or portion or none of it.
And actually, this is Paul, just to add a little bit in there that, again, the system, when you're entering the information into the system, the HICS or MA Health Connector, it will be calculating, and then you would see the results, and you'll be able, you as a certified application counselor, if you're assisting someone, would see the options that are presented to you based on the information that's entered into the system. So again, you wouldn't need to do the calculating. We're just trying to give you the background information so you understand how the system will be working, so that you will then be able to just explain to people if they have questions. And the next slide actually just points out the three different ways that the tax credits can be used. Nikki's already talked about it, but that just wanted to point that out, that we did break them out separately in case you want to explain or need to explain to the consumers who come to you that these are their options and if they're eligible for the tax credits.
Okay, great. So let's look at slide 18 for a moment. So in terms of calculating, again, Paul mentioned that you're not going to be doing the calculation. However, we want you to understand how it's done. So the amount of the tax credit is based on the premium cost of the second lowest cost silver plan. That's on the Health Connector shelf of health insurance plans, as well as the individual or family's expected contribution based on their income, which is a percent of the household's income a taxpayer must contribute based on their tax household FPL. So I personally like the graphics, because that makes me feel like this is a simple thing that I can remember. However, if you move on to the next page, on slide 19, you can see a little bit more detail by FPL. So very specifically, you can see the individual's FPL level, and we're starting above 133 from the health connector perspective. You can look at the income amount. You can see the percent of income, the expected annual premium contribution according to the ACA, and then the expected monthly premium contribution to the right. Okay. Just a couple of things to point out. Residents below 133 that will be eligible for Medicaid are ineligible for tax credits. Okay, so you have this as a good reference for folks to have handy.
Now, we also mentioned that before, that in the one of the earlier presentations we did, that the last point about residents under 133% FPL, that they would not be eligible. They'd be eligible for Medicaid, but ineligible for tax credits. So again, we're repeating some of the information, so we don't mean to confuse you, but just want to emphasize very, very important information.
So we're going to skip the scenarios. So those we think you'll be able to do with your staff.
But I just want to point out on slide 22, it's the sample scenario for family. That actually is a very good example of multitask household, which is on slide 23, which we're going to talk about. Because, again, multitask, looking at slide 23, again, when multiple tax households combine to form a single coverage group, the premium tax credit values provided during the shopping experience may differ from the maximum values presented during the process of eligibility. Again, the system would be highlighting this for you as you are assisting a consumer with this. Again, the premium tax credit for each tax household in the coverage family is based on the relative share of the premium that's applicable to each tax household. And as a result of the relative share calculation, a tax household may not be able to use its full maximum premium tax credit as it's determined at the time of eligibility. They may also forego some premium tax credit in order to enroll in a plan with another tax household. I know that's a lot of words, but then on slide 22, there's the sample scenario with the family that can help explain what we're talking about. I think it might be easier for you because on slide 22 there's a lot of information on that, and actually this scenario came about. It was feedback from one of our constituencies that we got this example, so we thought it was very important to share with all of you, because this is a real life scenario that was provided to us, and that explains very well what we just talked about for multi-tax households. Nikki, sorry.
So a couple of other updates we just want to bring your attention to. are around reconciliation. So if you move to slide 26, we really want to be sure that folks understand this. So taxpayers who receive advance payments of premium tax credits will have to reconcile the amount that they receive based on their estimated income with the amount that is determined based on their actual income as reported on their tax returns. So this means that people whose income for the year is higher than they previously estimated could have to pay back some or even all of the advance payments they received. On the other hand, people whose income ends up lower than they estimated could get an additional credit when they file their taxes. So because of reconciliation, enrollees receiving tax credits are encouraged to come back to the Health Connector and update their income information anytime. You're not limited to open enrollment. You can come back anytime, update their income, whether it goes up or goes down, so that they can maximize their premium tax credit or minimize the amount that they have to pay back at tax time. I think that's a really important thing to note for our consumers. The next couple of slides, and actually again 27 is really important to note as well. If the individual or family receives advance payments that are greater than the final credit amount for which they are eligible, the amount that they would have to repay would be capped if their income is less than 400% of FPL. So the caps range from $600 for married taxpayers, $300 for single with household income under $200, to $2,500 for married taxpayers with household incomes above $300, but less than $400. We have a hyperlink here to the IRS to get a little bit more information on this.
Actually, just so you know that the IRS, the reconciliation process is handled by the IRS at tax time.
Okay, so I'm going to jump, apologies for the speed, I'm going to jump to slide 35 and just look a little bit closer at connector care plans for a moment. I think we've talked this through, but this is where the content is when you're teaching your staff. We mentioned that, in addition to the premium tax credits in Massachusetts, people have an additional option of getting state subsidies. This is going to be through the Connector Care Plan. Remember, to maximize federal and state cost sharing and subsidies, this will only be done through the Connector Care Plan. Okay. So on slide 33, we've covered this. And I apologize, my numbers may be a little bit different than yours. But Connector Care Plans, again, we've looked at this, but just to reinforce, there will be a base premium tied to the income level if an individual chooses the least expensive plan. Cost sharing will vary by plan type, and individuals and families within a given income level will have access to the same co-pays regardless of the Connector Care Plan they choose. Those who choose non-Connector Care plans will pay higher premiums and higher cost sharing. You've seen the slide on, the chart on slide 33.
One that shows the Connector Care income threshold of up to 300% FPL. We covered that this morning as well.
And slide 37 really wraps it up. Just reminding folks that Connector Care Plans resemble Commonwealth Care Plans. Remember, but it is a little bit different. Connector Care Plans do provide access to comprehensive coverage. And only certain health insurance plans are going to offer Connector Care Plans. And after lunch today, other Connector staff are going to go through more specifics on the Connector Care Plan. So with that, I want to hand it over to Paul.
One more thing. After the assessment page there, you'll notice there's a section called Apply for Affordability Options. Again, we've covered some of this before, but it's beginning on slide 41. When are the federal and state subsidies are going to be available? Again, it will be for the open enrollment, October 1st to March 31st. And then at the back, you'll notice, starting on 44, there are some commonly asked questions. And then, again, the resources that are available online for you, as well as the other ones we've already discussed.
And I am Assistant General Counsel at the Health Connector. So I'm just going to spend about 15 minutes speaking to you a little bit about, at a high level, some of the types of authorized representatives and then other designations, and tell you a little bit more about the CAC designation form. Sorry, I can call that something else, but the Certified Application Counselor designation form, which is not quite final yet, but we will be sending that to you when it is final. But so I think folks are aware, and they're probably used to seeing the current forms that Mass Health and the Health Connector use for people assisting consumers to apply for health insurance. And these are the PSI forms, so the Permission to Share Information form, and the ERD, the Eligibility Representative Designation form. And so some of those are they're changing with the new ACA implementation. And so I just wanted to share with y'all at a high level what some of these changes are. So for the ERD form, that's going to now be replaced by the ARD form. A is for Apple. So the A in this stands for Authorized Representative. Because Authorized Representatives are able to take someone through not only eligibility, but also through the shopping and enrollment process, we felt like the name ERD was no longer really relevant. So just like the old form, though, there are still 3 scenarios where the ARD can be used. So the first scenario is when a member designates an authorized representative to assist them by completing the ARD form. And the second scenario is when the member is not able to sign. And the third would be when the authorized representative is appointed by law. So that would be when there's a court order or a healthcare proxy, or in other situations. So generally, an ARD allows the person to make all health insurance decisions on behalf of the applicant. So given this broad authority and responsibility, an authorized representative is typically someone who has an ongoing relationship with the applicant. So an authorized representative appointed by law, I just want to point this out, is not necessarily allowed to make all healthcare decisions on the applicant's behalf. It really depends on what the court has specified in their court order. So the second type of designation that I want to highlight for folks on the phone is the Navigator designation form. This is obviously a new form that we've created in collaboration with Mass Health. The form is only to be used by navigators. For the navigators, next week we'll actually be showing them the form, and this will be available on our website too. So the navigator form explains the role of a navigator, and it tells the person, the applicant, exactly what a navigator can do for them. It allows the navigator person to fill out and submit the person's application or eligibility review form and other eligibility-related forms. It allows the navigator to give proof of information given on these eligibility forms. It also allows the navigator to report changes in the person's income, address, or other circumstances. And the form itself also reminds all the parties, so the applicant and the navigator, that the navigator can only use a person's information solely for the purpose of helping that person apply for or get health benefits. And it also says that a navigator has a duty to maintain the confidentiality of this information in accordance with all state and federal laws. And then the back of the form has the navigator sign it and certify that he or she will at all times accurately transcribe the information provided by the applicant or member during the eligibility and enrollment process. So similar to the navigator designation form, there's also going to be a certified application counselor designation form, which is what you folks are going to use. This form is only to be used by people who have completed training and have been certified as application counselors. You have to give this form to an applicant, and they have to sign this prior to you helping them provide assistance. So this is the form. It's like I said, it's very similar to the navigator designation form. It explains the role of a CAC, saying that you will be helping them apply for health insurance through Mass Health and the Health Connector. And it allows CACs to provide information on insurance programs and coverage options.
helping fill out, submitting applications, eligibility review forms, and other eligibility-related forms. Work with consumers to get proof of information given on these eligibility forms. Help consumers respond to requests from MassHealth or the Health Connector about their application, and help consumers to report changes in their income, address, or other circumstances. And then again, it reminds the CAC that you have a duty to maintain the confidentiality of information received about the applicant in accordance with applicable state and federal laws. So like I said, this is the form that most of you are going to use. We will have that available, and we will send it to you so that you can print this out and use it regardless if you're helping someone online through our HICS IES system, the Health Insurance Exchange Integrated Eligibility System, and also when you help someone with a paper application. But I do also want to touch on the fourth type of designation. This is the old PSI, the Permission to Share Information form. This is similar to the old PSI form. So this form will allow a PSI to access certain information about an applicant or beneficiary. The applicant or beneficiary will indicate what information the PSI is allowed to access when they complete the PSI form. And for example, the applicant or beneficiary could permit the PSI to receive eligibility and enrollment information and information about eligibility for and access to MassHealth and Health Connector benefits. So you just have to, if you come into contact with these types of forms, the PSI or the ARD, you just need to see what type of information the applicant or member has allowed the person to actually do for them. So the purpose of this is really to give you a high-level overview of some of the types of designation forms that you're going to see, since some of these are new. But really the one that you will be filling out and using is the CAC designation form. And we will have that available to you before October 1st, before open enrollment. And we'll look to finalize that over the next couple of weeks. But about the paper application with you, and just give you some high points. I wanted to remind folks who don't know, that the current MBR that folks are used to using, the current application, has been redesigned. Oh, yes. So when I say MBR, I'm talking about the medical benefit request form for folks who aren't familiar with this application. So I just wanted to let you know that to be compliant with the Affordable Care Act and to ensure that we're asking all the appropriate questions that we need for eligibility through the ACA, we've worked very closely. Staff from the Health Connector and MassHealth have been working with our colleagues over at CMS to ensure that we were able to create an application that could, in fact, replace the existing one. But I have a couple of points just around, practically speaking, what people need to do now if they're going to use a paper application, and also what folks should, when folks will be seeing this brand new one. So I wanted to just say that if you are in fact assisting a consumer right now, so if somebody is seeking coverage prior to January 1st, they can either complete the brand new application that will be coming out shortly or submit the current medical benefit request form. The new application is going to have this yellow, it's not a sticker, but it's actually this big yellow box on the front page talking about how important it is to answer questions in Section 4. These questions are needed to determine eligibility for MassHealth Essential or for Commonwealth Care. So if somebody is seeking coverage right now, it's really important they complete those questions. Going back to the current medical benefit request form, though, if you still have those applications in your office, those current MBRs will be accepted until December of this year. Then beginning on January 1st, the new application must be submitted in the old MBR, the medical benefit request form, will be obsolete. Can't use it anymore.
if the old MBR is received after January 1, it's going to require further follow-up to ensure that we are getting the appropriate information that we need so that we can calculate modified adjusted gross income properly. So again, if you have the old MBR after January 1, please do not use it. And let's see. With this, just again on these couple of notes, as well as the visual for the yellow box, if you will, that information is in the member transition slides that we had presented earlier this week. There's a hyperlink to it on the MTF website.
And MTF?
Oh, excuse me, I'm sorry. The MTF website, folks, so it's called the Massachusetts Healthcare Training Forum, and EOHHS and the Health Connector have been working very closely with UMass Medical School to host quarterly statewide trainings. These are the in-person trainings that a number of you attend. Some of you may be new, so I just want to make sure that that we're able to alert you to not only this training opportunity, but as we mentioned earlier today, we're going to really follow up at these in-person events, conference calls as needed, really to support all the new information we've been sharing with you today. So if you have new staff at your office, please have them sign up for the MTF email listserv, and you'll get really important updates throughout the year. Okay. And then the other thing I really want to really stress, I mean, we tell you about the paper application, but whenever possible, if possible, we think it's really important to use the online application. So right now, if someone's seeking services right now, use the current virtual gateway system. It's the most efficient method of getting someone into subsidized health coverage. And going forward, use mahealthconnector.org to apply for benefits. So the paper application is always available to you. There are, as folks know, there are instances where it is definitely necessary. We're really trying to encourage using the systems to get folks in coverage as quickly as possible.
Thanks, Vicki. So this is Mary McGowan again. So I'm going to take the next 10 to 15 minutes and sort of walk through with you voter registration. And it sounds like at least some folks from a question we had earlier are sort of familiar with voter registration. And so this is just a reminder of what we're asking you to do. So there are slides for this. So on slide 2, I have laid out an agenda. And I just want to point out that we've asked you and your organizations to help us provide voter registration assistance to any consumers that you help apply for health insurance. So, and all of you and your organizations agreed to perform these duties as part of the agreement that you signed, and is also in our policy document. It references it. So I'm going to tell you what your roles and responsibilities are. I'm also going to just show you a voter registration form and how to use the form, and then what an applicant would need to complete this form. So on slide 3, you should be able to, after completing this training, provide guidance for completing and submitting a voter registration form, and then also document voter registration appropriately. So on to slide 4, we talked about the certified application counselor roles and responsibilities for voter registration. So I want to just emphasize to y'all that if you're helping someone with a paper application, then you should be asking them if they want to register to vote. But if you're helping them with the online application, we actually have built this into the system. So at the end of the signature page, it should actually show a person that if they would like to register to vote, here's the link, and they can download the form and do that themselves. But if you do help someone with a paper application, then you should be asking them if they want to register. So, so basically what you need to do is ask an applicant if they want to sign up to vote. you can explain, this is also key, explain to them that whether or not they register to vote, it will not affect their application for health insurance or dental benefits. So if the person that you're helping wants to sign up to vote, then we just ask that you explain how to fill out the voter registration form, but actually let the applicant fill the voter registration form out themselves. We also are asking that you document that the person either accepted or refused to register to vote, and indicate that that the person does not believe that someone has interfered with their registration process. Next, we're asking just to make sure that certified application counselors do not coerce anyone to register to vote. Please don't persuade anyone to make any particular voting choices. Also, you're actually not responsible for determining someone's eligibility to vote. We're just simply offering to help someone register to vote. And then finally, the certified application counselors, we're asking you to mail in the voter registration form. So the forms are actually, it's a one-page form front and back. And on the back side, it actually says, send this to your appropriate town or local election official within 5 calendar days after the person completes the form. So you would just simply have to fill in the town and stick that in the mail. So we're also going to provide you with a form called a declination form. So this is how you can document whether the person accepted or refused to register to vote. And I'm going to go over that in more detail in slide 8. So moving on to slide 5. The slide 5 shows the voter registration form up close. So this is a form which in Massachusetts is administered by the Secretary of the Commonwealth. And as I said, it's a one-page form front and back. I'm sure some of you have probably seen this before. But it has 14 fields for a person to fill out. And you can see the image on the front of the form that's on the slide. I just want to note that at the bottom of the slide are the filing deadlines. So you can just reiterate to the person if it's a few days before an election that these are the filing deadlines. So on slide 6, I'm going to go into more detail on the 14 fields. So this is basically how to use the form. So on the first question, it just asks to check off which boxes apply to the applicant. So the first one, are you a citizen of the United States? And will you be 18 years of age or older on or before Election Day? Then the second field, it asks for the person's full name. And in the next box, the person's former name. The next box asks for the person's address, where they live, and then the address where they receive mail if that's different. Number 6 asks for the person's date of birth. Number 7 asks for the person's driver's license, Social Security number, or none if they have neither. Next, the person's phone number. And then I just want to point out the next couple of fields are important for your purposes, but field number 9 asks for the person's party affiliation. Again, I just want to highlight that you should not be persuading people to pick a party affiliation. 10 asks for the person's address where they were last registered to vote. Field number 11 asks that if the person received assistance completing the form, that the individual who helped them print his or her name and address and put that information in number 11. So that would be you. So if you've helped someone fill out the form, please put your name and address in field 11. For field 12, it just asks for the person to read the oath. So if the person needs help reading it, you can read the fill out to them. Otherwise, have them read it and then have them print the date and sign their name in 13 and 14. So this form is actually, it's available on the Secretary of State's website, and it's available in not only English, but also Spanish and Chinese. So we're, I think actually at the end of this, slide 14 gives you a link to where you can download the form in all 3 languages. So on the next slide, that's titled What the Applicant Needs to Complete the Form. So basically, and this is just for your knowledge, but part of this you don't have to tell them, or you don't, I'm sorry, you don't have to tell them. You have to tell them this, but you don't have to actually determine their eligibility to vote. So the first one is that in order for them to complete the form, they should be a U.S. citizen, and they should be a Massachusetts resident who's at least 18 years old on or before Election Day. But that, again, is not for you to determine for them. They do have to understand the form that they're filling out in any of the languages that it's provided. In order to be registered, they need to complete the form, obviously in a legible manner, and they must provide their personal information, including their full name, address, mailing address, date of birth, driver's license number, or Social Security number. And then they must sign their own name. So as I mentioned before, the declination form is on the next slide. I believe that might be slide 9 for folks. So this is a form that we will provide to you, and it basically, it helps you document how someone has either declined to register to vote, if they want to register to vote. And so Part A asks the applicant I'm going to quote now, if you're not registered to vote where you live now and you are eligible to register to vote, would you like to apply to register to vote here today? So the person can answer yes, no, or already registered where I live now. And it then asks them to sign their name and date. You're going to keep that first part of this form. And Part B is for your use, and it allows you to keep track if the person registered to vote, did not register, or is already registered where they live now. Part C of the form is the applicant's copy. You can cut this off, share this off for them to keep, and it basically just explains for their records that they, I'm going to quote from the form, are applying to register or declining to register to vote will not affect the amount of assistance that they will be provided by this agency. So it goes on to tell the person that if they believe that someone has interfered with their right to register or declined to register to vote, that they may file a complaint with the Secretary of State, and it directs them on how to file that complaint. So please keep copies of the declination form for your organization. So that's really it for the formal part of the presentation, but I was going to walk through some of the assessment questions just to make sure that everyone understands the key messages. So I'll go through these fairly quickly. So the first question, does the CAC have a responsibility to ask the applicant if they want to register to vote? So obviously the answer is yes. So a CAC has the responsibility to ask the applicant whether they want to register to vote. Second question, once the individual completes the voter registration form, how many days does a CAC have to send it to the appropriate city or town local election official? The answer is C, 5 calendar days. And the third question, when signing up for a QHP or qualified health plan, who should receive the declination form for voter registration? The options are A, applicants declining the opportunity to register to vote, B, applicants accepting the opportunity to register to vote, or C, both. So we want you to use the declination form regardless if the person actually registers to vote or not. So with that is the next slide is the summary. So hopefully now you're able to provide guidance for completing and submitting the voter registration form and document that appropriately. So there are resources on the next slide, and please download copies of the voter registration form to have available. And they are available, once again, in English, Spanish, and Chinese. So I really appreciate you thinking through that. I know some of you are familiar with the voter registration form already, but we thank you and appreciate your assistance with this.
So I'm Ed D'Angelo. I'm the General Counsel at the Health Connector. I want to first thank all of you for your willingness to work with us and help us in this project of registering and enrolling people in these new insurance affordability programs. So thank you. The training that I'm going to be delivering is on privacy and security standards. I know many of you work for HIPAA-covered entities, and so you have been trained in privacy and security standards and procedures and are familiar with that and live in a HIPAA-sensitive culture. But, you know, it's always good to reiterate these things. We are required to do training on privacy and security for certified application counselors. And there are some slight differences because of the new, under the new law, between the information that you'll be getting through assisting these people and HIPAA information. So we'll just highlight some of those differences. We'll read. I hope you have the PowerPoint that we put together, the agenda on the second slide. We're going to be doing an overview of privacy and security requirements in the context of the work that you'll be doing as certified application counselors. We'll be talking about safeguards for protecting personally identifiable information, and then we will be discussing some procedures for identifying and reporting problems. On slide 3, after completing this training, you'll be able to recognize personally identifiable information, and you'll know what to do to protect that information and how to safeguard it in the work that you will be performing. So let's do an overview first of what really we're talking about, what kind of information we're talking about. So I'm sure those of you certainly who've been trained in privacy and security through your work at hospitals or community health centers or other covered entities are familiar with the term protected health information, and that's a term that comes from HIPAA, which is the federal healthcare privacy law. And protected health information is basically personally identifiable information about an individual that is related to that individual's receipt or payment for healthcare services. And because it's identifiable and because it relates to healthcare, it is protected, and you have a variety of safeguards and privacy rules about that information. When we talk about information relating to applying for programs through the exchange, we use a very similar term, which is personally identifiable information. It's a slightly broader term legally, and it essentially means information about an identifiable individual, so you don't have that extra piece about related to obtaining or paying for health care. As a matter of fact, everyone who's coming to you will be applying for health insurance and or Medicaid. So essentially, within your context, these two terms are the same. I may use them interchangeably, but whatever you've been trained about protecting PHI would apply to protecting PII. So it's kind of a legal distinction that in your case doesn't mean anything. What you take away from this is if it's personally identifiable information, it's private, it really belongs to the person who's giving it to you. They have a right to have that information secure. You have an obligation to keep it private, to keep it secure, to enter it accurately into our systems, and to take administrative, physical, and technical safeguards to keep that security. And I think you all know that. Just to reiterate, personally identifiable information can be found in any form. So if someone is speaking to you, if it's in paper or if you're entering it electronically into the system. It consists of the conversations you're having with the member. Many of you will be talking with them face to face, and in those conversations, you have to be careful that you're not inadvertently disclosing information as the member is giving it to you or as you're talking about it. You may be converting it into paper, depending on how you do your work. You certainly will be entering it into an electronic system, and all those records, the electronic records, the paper records, that's all PII, and it all must be protected. We don't know or anticipate that you'll be emailing, but obviously if you're emailing PII, then you are using it and potentially disclosing it, and that's restricted. We'll talk about those restrictions. It is potentially possible that you could be loading PII onto a portable device like a laptop. That's generally not best practice to do and should be avoided. And there are some restrictions on that. Okay. So on the next page, what is privacy? So privacy about information is about the individual's ability to control their personal information and the responsibilities of the organizations that collect or use that data. So there are privacy requirements under HIPAA, which has been in place for a number of years, and that applies to hospitals, community health centers, health insurers, the Medicaid agency, and other health agencies. And then the exchange final rule, which is the rule that governs the programs, some of the programs that we're talking about, like the federal APTC programs and the cost-sharing reductions, and the applications for that. That also contains federal privacy and security standards, which again are very, very similar, and they're based off of each other. So it's two different nomenclatures, it's two different ways of talking about it, but they essentially come down to the same thing, which is a high degree of sensitivity to privacy and security. And when we talk about security, there are two features of that. There's confidentiality, so what you're being given, you're being entrusted with an individual's personal information, and you need to get that information in order to perform your work, in order to help that person obtain health insurance or health care coverage. But then you have an obligation to keep that information confidential. You know, at a high level, you can only use it for the purposes you've been given it to. You can't disclose it to a third party unless it's necessary to perform the work you're doing it and it's consistent with the governing laws. You can't inadvertently disclose it, and you have to limit your own access to personal information to only that information that's absolutely necessary for you to do your job. And you also, as you're using this information, have to engage in safeguards, in practices or best practices, procedures and policies that will prevent inadvertent disclosures. And you also have to be on the lookout for any signs of any malicious tampering with personal information, and you have to report if there's been any violation or any incident that violates those practices and procedures. So, the next slide, hopefully by now you know the answer to this question, and we just do that to orient you within the context of this training. So as certified application counselors, you are going to be assisting individuals and families to obtain health insurance, and you will, in order to do that, will be collecting information from them, probably orally, potentially in writing. You will be entering it into an electronic system, so you will be conveying that information to us. If you're at your screen and you are you're there while we respond to the information you have entered, you will also be receiving personal information from that person. So you will be receiving PII from the individual, you will be receiving PII on that individual's behalf from the HICS, from the Health Insurance Exchange. You will be transmitting information as well, and you'll be using it. So you've already learned about the designation form that you're going to be filling out, and part of that form is going to be the individual's acknowledgement that you will be receiving personal information for or about him or her, and his or her consent to that you can use it and that you can receive information. So it's critically important to protect you and him that you have that designation form completed. That's our way of knowing that you have the permission from the individual to receive their personal identifiable information. So slide 9, I think we just talked about that. You will be seeing information in the course of helping them. You'll be using that information, and so therefore you have a duty of confidentiality and security under state and federal laws. Okay, so why are you getting this training? I think we covered that at the beginning. It is a legal requirement under HIPAA and under the exchange regulations, which apply to us and are now governing this program that healthcare organization employees, staff, volunteers, students, etc. of healthcare organizations be trained about privacy and security because it's a critical component of delivering good healthcare, and it's not just our legal requirement. It makes good sense. It's critically important for the organizations that you work for that you treat information securely, and that because there's legal liability, there's a reputational interest at stake if personal information is misused or lost. And this presentation will review the key security procedures and safeguards and what is expected for you. It's everyone's obligation to do it. I'm sure you're sensitive to that, and I'm glad we have this opportunity just to review these high points. Okay, so we're now going to talk more practically about how you will in your work protect personally identifiable information, PII or PHI. So what are the biggest dangers? The biggest dangers come from people, insiders and outsiders. PII can be misused or wrongfully disclosed either through inadvertence or through malice. So, we can talk about safeguards that can protect against both these things. Obviously, a lot of safeguards are built into the electronic system that you'll be using. We also have legal safeguards like the disclosure form, again, to protect everyone. It's a document that you have permission to receive information, but there will come a point when it's just you're responsible for the information that you receive. And so the procedures are in place to prevent accident. We're all busy, you're all busy, you are doing multiple things. You need to have these procedures in place, and they have to be second nature so that in the busyness we don't inadvertently disclose or misdirect or have an unpermitted disclosure of personal information. And we also need to be sensitive about ways in which we can protect the integrity of the system that you'll be accessing. Okay, so on slide 13, what are the procedures for collecting information? Am I going too fast? Okay. All right. So certified application counselors will assist an applicant by helping them to fill information into the online system. You have to begin by having the applicant fill out the designation form, which will explain your role, and in particular relevant to this presentation, your role in collecting personal information. Now, it goes without saying, when you enter information on an individual's behalf, you have an obligation to enter it accurately, because that becomes part of that individual's record, and it becomes the basis for the individual's determination of eligibility. You must collect the information from the individual in a way that ensures that the information is confidential. You should be entering it into the system where it will be retained, it'll be acted on, and it'll be retained in a secure way. You should not be personally retaining that information. You should avoid printing it out. You should not be downloading it. You should not be writing it down. And if you do any of those things, then you are obligated to ensure that the places where you've downloaded it or written it are kept secure and are promptly destroyed after you no longer have a use for them. So ideally, this will be entered through a conversation into a system. You'll just be the conduit for the information. You won't be creating a permanent record in your own systems or in your own workplaces of this information, so that will relieve a lot of the potential for inadvertent disclosure. Once we get the information, you can rely on us to treat that information securely. We will also be giving information back to you, so there'll be information that will be displayed on the screen, which you'll be responsible for conveying to the individual. And again, if any of that information is printed, downloaded, or transcribed in writing, then those records contain PII, and they have to be held securely until they're no longer needed, and then destroyed in accordance with standards under HIPAA and under the exchange rules. On page 14, these are the basic principles of collecting PHI and PII. You have a right or an ability to obtain PII from individuals only for the purpose of assisting them to apply or enroll. It's for no other purpose. It's not for marketing purposes. It's not for research purposes. It's not for data collection purposes. It's certainly not for curiosity or entertainment. Information should be collected only by the persons who are needed to provide that assistance, only by persons who need the information in order to do the work that you've been certified to do. So, it should be restricted. There shouldn't be unnecessary people that are part of these transactions, and you should not be disclosing the information to people whose knowledge is not necessary in order to perform the necessary functions. And you should only be collecting the minimum amount of information necessary to provide the assistance that you're being called upon to provide. So those are the three cornerstones of HIPAA, and they all apply to these transactions. On page 15, we talk about disclosure. So I said at the beginning, obviously you're collecting information from the individuals. You're then going to be transmitting that information to us. It's clearly permitted for you to transmit the information through the HIC system, and that's permitted, A, because it's necessary to perform the function. We need that information to serve the person and to determine their eligibility, and B, because we know from our system and from our agreements with you that transmission will be secure. That electronic transmission will be secure. But that's the only disclosure that's permitted. You should not be disclosing it to other people without that individual's written consent. It is prohibited to disclose PII received from the individual for any purpose other than assisting with an application or enrollment unless authorized in writing by the individual or required by law. If you think it's required by law, that's something you would need to consult with your the legal authorities in the organization that you work with, because it's not a judgment call, a subjective judgment call. It's a very limited and narrow set of circumstances that probably would not apply. Disclosures include any communication, written or spoken, intentional or inadvertent. So a misdirected email is a disclosure, and it's an unpermitted disclosure, and it's something that triggers liability for reporting. And so even a minor inadvertence can lead to a problem. And so that's why it's really important that you only enter the information into the system, that you not share it, that you not create multiple records of it, all to avoid an inadvertent disclosure. So how can we prevent an inadvertent disclosure? So page 16 goes over some very, very common sense procedures that hopefully are already incorporated into your workplace, but they should be incorporated into the work that you do as certified application counselors. So when you conduct the individual intake, you should be in a private location where you can't be overheard, where information that the individual is showing you or that's being displayed on your screen cannot be seen by a passerby, even by a coworker, because the coworker does not need to see that information because you're the one helping the individual, not your coworker. So the place and the physical location and the space are really important in terms of preventing inadvertent disclosure. Don't discuss the individual's information except when required for work. And if you are discussing it, be careful and be conscious of where you're doing it. So I think, it's become part of culture at covered entities. Don't talk about patients or covered individuals in the elevators. Don't use your speakerphone if you think the person has a left you a voicemail message that may contain PII. And again, it could be just the person's name would be PII because it would be in the context of them applying for or receiving government subsidized health insurance. Lower your voice when you're speaking to the person or about the person. If the person gives you documents or records, and that may be the case that they show you records, they should never be left unattended. Think about whether you even need to retain those documents, because this is something, if you're doing a one-time assistance, then you may not need to retain those records. If you do retain any records as a result of these transactions, if they're in a paper form, they have to be locked in a file cabinet, drawer, or briefcase. Don't leave confidential papers on your desk, printers, fax machines. If they're on your computer, then the computer has to be password protected, and it should not be displayed on a screen if you leave your desk. If you have paper that contains PII, including a name or phone number, it must always be shredded. You should have the ability to have paper shredded at your organizations or your workplaces. If you're required to send an email containing PII, the email must be sent through an encrypted system, and it must be sent only to persons authorized to receive PII. So an inadvertent direction of an email, which happens that you can sometimes hit reply all when you didn't need to or mean to. You can, the name can auto-populate and it can be the wrong name. Everyone's had those experiences, and it can be embarrassing, but if it involves PII, it can trigger legal liability and lead to breach reporting, and that's something we have to avoid. So I don't know if you'll need to be emailing information about the individuals that you're serving, but if you do, you have to take special caution, and if possible, it should be avoided, because emailing PII is always a risky business and creates just a chance of inadvertent disclosure. Page 18 are some more practical tips. Check the computer screen angle, the angle on your computer screen. If it's visible to the public, adjust it or use a filter. When leaving your work area, put away confidential materials, log off, lock, or shut down your computer. If you're working in a secured area, or if you have records in a secured area, be aware of visitors or strangers who don't belong there. Keep locked doors locked. When entering a secured area, close the door after you. Don't have to be nice and let someone who doesn't belong there come in. Okay, now when you start, and I think it's probably already been explained to you, you'll be entering the system on an individual's behalf, in a sense almost as their alter ego. We expect that at some point there may be a portal that you will be able to use, and if you do enter that portal, you'll have a password. This is a privilege. It's going to make your work easier. It's going to give you access to more information, and so therefore it carries responsibilities. And so on page 19 and 20, we're going to talk about some of those responsibilities. If you have access to multiple files, you only should be looking at the file or files that you need to perform the work that you're doing. You shouldn't be browsing through files. You shouldn't be looking at things that are not necessary for your work. And we'll have audit trails on these systems, and so it's not something that should be done or could be done, because it's something that can be tracked. No browsing. Access only an individual's record for a need, not out of curiosity. Access records only for a case you're working on, not for other individuals, and certainly don't reveal information about one individual to another individual that you're helping. When you have a password, again, this is a commonplace now for all of us, because we use so many electronic systems, but it needs to be repeated on page 20. A good password is something that's good for you to remember and hard for someone else to get. So password 1 is not a good password. 1, 2, 3, 4 is not such a good password. I think we all know that we have to have complex passwords. You should, these are tips. Make up your own secret method. Pick a theme with letters and phrases. We all struggle with this, but it's absolutely essential when you're dealing with PII. Don't share your password. Don't put it on a little yellow sticky next to your computer. If you think someone else knows it, change it. Follow standards that the system will give you for password length, content, and frequency of change. And don't use the same password everywhere. On page 21, so this is, I think, most of the reports I've read, and I'm sure people in your organizations have thought about this too. Most of the significant data breaches have occurred because of use of portable devices. So by definition, they move around, they can be more easily lost, and they can store a lot of data on them. I don't know that you will have occasion in your work as certified application counselors to download data. I hope not. I hope you will be entering the data into the system from your computer at your workplace and at that workplace only, and that you won't be downloading. But if you do use a portable computer, and if that portable computer or other portable device has PII that you have received in the course of your work as a CAC, it must be encrypted. It can only be used to the extent necessary to perform your duties. You have to use great care when you're taking these portable devices outside your facility. Don't leave them unattended, unlocked in your cars, in public places, in Starbucks. And then again, if you're using them and displaying the PII, that again has to be in a place where you can't be seen. The PII has to be destroyed after you've stopped using it. And I think I mentioned encryption. Any portable device or electronic medium that's used with PII on it must be encrypted. Okay. So identifying and reporting problems. So on page 23, I think by now everyone is familiar with the obligations, the legal obligations that apply to your organizations and that apply to us as well, to identify potential incidents in which personal information can be misused or improperly disclosed, and then to report it. And the reporting is both to the individual who has been harmed by the breach and to government agencies. And so we'll go over some of those requirements. Just at a high level on page 23, an incident is a violation of security policy or procedure. An incident is considered a breach if it results in an unauthorized disclosure of PII. So an incident would be a misaddressed email. If the email contains information about an individual, a member, an applicant, then that becomes a security breach. So you must immediately report any suspected or actual incident. If the breach involves a loss of PII received from or transmitted to the HICS, then it must be reported to the Health Connector in Mass Health, and we have a number at the end of this presentation where you have to report that. So that has to be done by your organization. That's a legal requirement on them, and then we have to act on that. The institutions or the organizations where you work should have policies and procedures on reporting, and you need to follow those policies as well if there's a breach, and you'll want to go through that as well. Okay, these are on page 24 as examples of some incidents that should be reported. Records containing PII are found in an unprotected area where they shouldn't be. A laptop is stolen. I mean, that's a big one and sort of an obvious one. You learn of an employee looking up PII when they shouldn't. A computer is left logged on and unattended with PII showing. It becomes a breach. A fax with PII on it is sent to the wrong number. An email with member information is sent to the wrong person. A flash drive with member information is lost. A computer is infected with a virus. So then that's an incident that has to be investigated to determine if PII has been compromised. So these are incidents that should be reported to someone who can then determine, was PII involved, what was the nature and sensitivity of that information, who needs to be notified, what the appropriate reporting is. When you're logging into our system through the portal, if there are changes in the way your screen looks or new icons or software shows up unexpectedly, you should report that internally, so that because that could be the sign of some form of tampering. If your computer is persistently much slower than usual, that could also be the sign of some form of tampering. On page 26, breach reporting. Your organization has obligations to report certain breaches involving PII. They have obligations to us, and they also have obligations to government agencies. Information breaches of PHI must be reported to CMS. Under HIPAA, breaches involving personally identifiable information must be reported to the State Attorney General's office and to the individuals under state reporting laws. And we are under obligations to CMS as well. By we, I mean the Connector and Mass Health, to report breaches of information that we have provided to one of your institutions. So there are a number of reporting requirements that are triggered. And this is the number on page 27 that that is your way of making the first line report to us when you have determined there's an incident, you've made the internal reporting in your institution, and you've determined that the incident has compromised personal information obtained from or on our behalf. Okay, sanctions. We have to go through sanctions because they're important to know about. So all of these laws that we've talked about, HIPAA, the exchange rule, state breach reporting rule, all contain sanctions that can be applied to your organizations, that can be applied to us, or that could be applied to individuals who violate the laws. So federal and state laws may require organizations to notify professional credentialing bodies if necessary, because privacy and security is part of healthcare professionals' obligations, as well as law enforcement and various federal and state agencies. Violations of federal and state laws can lead to civil and criminal penalties, including fines and imprisonment. I'm sure you've also been trained in your own organization that violations of policies around privacy and security can lead to discipline within the workplace, and it can lead to us canceling the ability of your organizations to serve as certified application counselors. Sanctions under HIPAA and set forth in, on page 30. Violations of HIPAA are punishable by fines and by imprisonment. And if it's committed with fraud, the penalties are increased. And if it's committed with the intent to perform identity theft or cause some other malicious harm, the penalties are quite severe. But I think it's worth noting that even a non-fraudulent violation can lead to significant fines and criminal sanctions. Under the exchange rule, a violator who knowingly or willfully uses or discloses information in violation of the privacy and security requirements of the Affordable Care Act is subject to a civil penalty, in addition to other penalties that may be required by law. There are also penalties for, there's also, your organization can be subject to lawsuit for violation of the state's breach reporting requirement. We have a short assessment here, starting on page 33. And so, what? On a piece of paper? No. Oh, okay. So what is considered personally identifiable information, or PII? So why don't we go through these and you can circle the answers, and then we'll go back and we'll see if you guessed right. So A copy of an invoice with premium amounts for a health insurance plan, an email with subject containing an individual's name, a fax cover sheet containing an individual's name and home address, a telephone conversation discussing the status of an individual's application. So circle the one or ones that you think constitute PII. Okay, which of the on page 34. Which of the following is not a good measure to take for keeping information confidential and safe? A, don't discuss plan members or other confidential information except when required for work. and be aware who might overhear you. For example, talk in a more private setting, lower your voice, or turn off your speakerphone. B, don't leave plan member records, documents unattended. Lock them in a file cabinet drawer or briefcase. Don't leave confidential papers on copiers, printers, or fax machines. C, never shred paper containing confidential information, including patient information, name and phone number, once thrown away. D, when faxing confidential information, use cover sheet with a confidentiality notice. Double check the recipient's fax number, make sure the recipient is standing by, wait for confirmation from machine or recipient. If it's misdirected, contact the recipient and request document destruction. Assessment, the last assessment question on page 35. In which of the following incidents should you file a report? More than one may be correct. A, member records are found in a secure area where they should be. B, a laptop possibly containing confidential information is stolen. C, an employee looks up member information, for instance, a family member, a friend, a VIP, when they have been given instructions to do so. D, a computer is left logged off when unattended. E, a fax with confidential information is sent to the wrong number. F, an email with member information is sent to a group of people when only one person should have gotten it. G, a flash drive with member information is lost. H, a computer is infected with a virus. So those are the three assessment questions. I hope you've all answered them, and I hope you all got them correct. What is considered personally identifiable information? Can everyone hear me? I guess we don't know if you can. All right. What is personally identifiable information, or PII? The answer is all of the above, because all of the above contains information about an individual, and that's really the essence of PII. So it can be as simple as a name and an address. Question on 34. Which of the following is not a good measure to take for keeping information confidential and safe? And C, never shred paper containing confidential information once thrown away. So the key here is not only do you have to throw it away, which you have to do, but you have to shred it before you do that. You should have the ability to shred it, and if you don't, then you probably really can't have PII in paper form, or you can't use it in paper form. And I think the real takeaway here is you need to get rid of it as soon as you're no longer using it. So don't let it pile up on your desk. The others are all good measures. Don't discuss confidential information except when required to. Don't leave records unattended, and if people still fax stuff, use a cover sheet with a confidentiality notice. Double check and then make sure. So faxing is not a best practice for PII unless absolutely necessary, and it shouldn't be in this in the context of your work as a CAC. But if it is, then you need to follow these directives. Emailing is also a source of risk, although it does have to be used at times. Okay, on page 35, in which of the following incidents should you file a report? The only incidents in which you should not, you don't need to file a report are A and D. Member records are found in a secure area where they should be. That's okay if it's secure. A computer is logged off when unattended. That's what's supposed to happen. All the rest of these are incidents that are reportable. The obvious one, a laptop potentially containing confidential information is stolen. That has to be reported and investigated. And then a risk assessment made about what information was potentially on it and what reporting requirements are triggered. A computer is left logged off when a fax with confidential information is sent to the wrong number. An email is sent to the wrong person. A flash drive is lost. A computer is infected with the virus. That's something that requires investigation, because it could mean that it could mean that the system has been compromised and personal information in that system is at risk. Okay, so let's summarize what we've done. You should now be able to recognize personally identifiable information, which is confidential. You should realize that it's essentially the same as PHI, if that's a term that you've been trained in. It's information about an identifiable person that you get in the course of your work as a CAC. And now you also know what you need to do to protect that information. You must collect it in a way that ensures its confidentiality. You must use it only for the purposes that you are collecting it for, which is to assist that person. You must not disclose it except as necessary to perform the work and not to a third person. You must engage in administrative, technical, and technical safeguards to protect against the inadvertent use or disclosure of the information. And if any of those procedures have been violated, or if you have reason to know that someone else has done it, you have to report immediately in accordance with your organization's reporting requirements, and report to us when it's PII that has been received from our system.
All right, thanks, guys. So I know that you just listened to a lot of legal requirements, and unfortunately, I have to talk about another legal requirement around conflict of interest. So I appreciate your patience and sitting through all these presentations today. We are almost done with the afternoon, though. So on to conflict of interest. So you should have slides before you, and I'm really just going to talk to you today about conflict of interest standards that are required for every person and organization who is designated as certified application counselor. And these legal standards come from federal regulations. They govern both the Health Connector and Mass Health, and some of these are certainly new for all of us. So if you have questions, please let us know. So on slide 2, we lay out an agenda which includes defining a conflict of interest, the conflict of interest regulatory requirements. Also, I'm going to talk about the other conflict of interest requirements, such as the ones that come from the contract that your organization signed with us, and also there's a policy document that references a few other conflict of interest requirements. And at the end, there's going to be an assessment, as we've gone over before, with questions to test your understanding. Slide 3 just shows the objectives of today's training, which is for you to be able to recognize a potential conflict of interest, and also that know what to do when you think you or someone else or your organization has a potential conflict of interest. So on slide 4, conflict of interest is a term that is pretty colloquial. I feel like people they've used this term a lot. You know what it means. But here we really have a very specific meaning for conflict of interest. So on slide 5, I've defined the term conflict of interest here to mean that a CAC, Certified Application Counselor, has a private or personal interest sufficient to influence or appear to influence the objective exercise of his or her official duties. So I just want to point out that a conflict of interest can be both a personal conflict of interest as well as an organizational level, like an institutional level conflict of interest. And this example points out a personal conflict of interest and says that a CAC has a conflict of interest if he or she also works for an issuer, a health insurance company, and specifically refers members to enroll in a health plan with that issuer. So what do we mean when we're talking about conflict of interest in this case for certified application counselors? We're really talking about relationships that you or your organization has with insurance companies. That's the context for federal regulations. And these relationships can be financial or they can be non-financial. It's just something that is sufficient to influence or appear to influence your actions. So another example of this would be that if you give advice to an applicant to pick one health plan over another, and that's because of your relationship that you have with the health insurance plan. So on the next slide, I'm going to talk about the regulatory requirements that apply to conflicts of interest. On slide 7, so I've picked out some excerpts here of the federal regulations. And the top part goes into the federal exchange regulatory requirements. So these are ones that govern the exchange or the marketplace, as it's referred to. And in Massachusetts, this is the Health Connector. So these requirements state that, quote, an organization designated by the exchange to provide certified application counselor services may certify a staff member or volunteer to perform the duties only if the staff member or volunteer discloses to the organization, to the exchange, and potential applicants any relationship the certified application counselor or sponsoring agency has with QHPs, its qualified health plans, or insurance affordability programs, or other potential conflicts of interest. And they must agree to act in the best interest of the applicants assisted. So it also goes on to state that, quote, organizations designated by the exchange and certified application counselors may not impose any charge on applicants for application or other assistance related to the exchange. So similarly, the Medicaid regulations, which govern our Mass Health program, state that, and this is on the page at the bottom, quote, to be certified, application assisters must be trained in and adhere to all rules prohibiting conflicts of interest, including all other state and federal laws concerning conflicts of interest and confidentiality of information. So essentially the key takeaway here is that certified application counselors must disclose to us and to consumers that they assist if they have a conflict of interest or if their organization has a conflict of interest. So in the next couple of slides, I talk about other conflict of interest requirements. So on slide 9, so some other requirements regarding conflict of interest are that you must provide information about the full range of insurance programs that are offered by Mass Health and Health Connector. So said another way, if your organization has an exclusive contract with one particular health insurance company, when you're assisting a person apply for health insurance, you must not only tell them about that one insurance carrier, you have to tell them about all the plans and options that are available to that person. So we're also asking you and the person you're assisting to fill out this certified application counselor designation form, which I mentioned earlier, Ed has mentioned in his talk as well. This form also asks for you to declare to us that you have disclosed any organizational or individual conflict of interest to the applicant that you're assisting prior to assisting them. And it also tells the applicant that you have agreed to act in their best interest. So just to remember, you must have that person fill out the CAC designation form prior to assisting them. And this is online or in paper. So until we have the Assister portal available to you, you need to fill out the certified application counselor designation form, regardless if you're helping the person apply online or on paper. So I know I've walked through that pretty fast. I think I'm going to actually go through the assessment with you because I think these examples really help understand and demonstrate the types of conflicts of interest that I'm talking about. So on slide 11, it just says that this concludes the conflict of interest practice section of this module, and we will continue with 3 questions. So slide 12 is the first question. This is true or false. And by the way, I just want to say that all names used in this presentation are fictional. If Helping People, Inc., which is a CAC organization, is bought by Provincial Health Plan, a health insurance plan/issuer, this means that Helping People, Inc. has a conflict of interest. True or false? So I'm going to go ahead and tell you the answer to this. So the answer is A, true. So Helping People, Inc. would now have a conflict of interest because Provincial Health Plan is a health insurance issuer. So they would just have to disclose this to us as well as to the applicant that they're assisting. On to the second question on slide 13. This is pretty lengthy, but I will read this out loud. Health Enroll Now, which is a nonprofit advocacy organization based in Western Massachusetts, is designated as a CAC organization by the Health Connector and EOHHS in September of this year. In February of next year, 2014, Health Enroll Now is selected for a grant from Springfield Health Plans for outreach and enrollment of residents in Western Massachusetts into Springfield Health Plan insurance products only. Does this situation present a conflict of interest? Why or why not? Option A, yes, this is a conflict of interest because Springfield Health Plan's grant conditions are sufficient to influence or appear to influence the objective exercise of the CAC organization's official duties. B, no, this is not a conflict of interest because Springfield Health Plan does not buy Health Enroll Now. C, yes, this is a conflict of interest because CACs cannot take grant money from a health insurance issuer. Or D, this is not a conflict of interest because Health Enroll Now is not a health insurance issuer. So does this situation present a conflict of interest? The answer is A, yes, this is a conflict of interest because Springfield Health Plan's grant conditions are sufficient to influence or appear to influence the objective exercise of the CAC organization's official duties. So this obviously goes back to the definition that I pointed out on slide 5. So what you should do about this is obviously you'll need to disclose this to us as well as to the consumer that you're assisting. So the last question that we have in the assessment section is on slide 14. So Natalie is hired by a community health center in central Massachusetts to be a part-time CAC for people in that area. CAC Natalie needs another job to pay for her graduate degree studies in public health. So she applies for and is given a part-time job working at a customer service center at Bay State Health Plan, helping people enroll in Bay State Health Plan insurance products. Does this situation present a conflict of interest, and why or why not? So the options here are A, yes, this is a conflict of interest because CACs cannot be employed by community health centers. B, yes, this is a conflict of interest because CACs cannot work part-time. C, yes, this is a conflict of interest because working for Bay State Health Plan part-time could influence or appear to influence the objective exercise of CAC Natalie's official duties as a CAC. Or D, no, this is not a conflict of interest. So giving folks a few seconds to think about this, but the answer is C. Yes, this is a conflict of interest because working for Bay State Health Plan part-time could influence or appear to influence the objective exercise of CAC Natalie's official duties as a CAC. So obviously, in that situation, CAC Natalie would have to disclose to us and also to the consumer she's working with that she has a conflict of interest. So on the summary slide, hopefully now you're able to recognize a conflict of interest and know what to do when you think you or someone else may have a potential conflict of interest. And you successfully completed the training. I can take some questions now, but I will ask that.
My name is Allison Keene, and I'm here with the Health Connector, and I'm going to take you through the couple of sections here, the overview of ACA changes to Health Connector plans and products section. So hopefully everyone has the materials in front of them, and just to walk through at a high level what our agenda is going to be for today, for this section at least, we'll go through sort of ACA changes to the health insurance market in Massachusetts generally, ACA changes specifically to the Health Connector, the certification of Health Connector products and plans, so just a little bit about our process for that, and then kind of what some of our products and plans are as well. So we'll end all of that, as you've been familiar with from the other sections, with an assessment and summary, and we'll also make sure to leave some time at the end if you have any questions, which I'm more than happy to take. So I'll go ahead and jump right in. Just to kind of touch on some of the objectives of this section, the first one is really just to get you familiar with the changes that are happening in the Massachusetts health insurance market, of which there are, as you know, many, as a result of the Affordable Care Act. The second one is to kind of make sure that you understand what the definition and requirements are for plans that we call qualified health plans and qualified dental plans, which are offered on the Health Connector. And lastly, to look at some of the specific QHPs and QDPs, as we call them, that are offered through the Health Connector.
So as I said, the first section, we're just going to kind of think about the changes to the health insurance market in Massachusetts broadly. And the first slide there is really just looking at what the changes are to the sources of coverage in Massachusetts, and really looking specifically at some of the things that have changed before ACA implementation, which is before 1/1/2014, and then after ACA implementation, after 1/1/2014. So if we think about how the ACA affects where individuals, families, and small businesses, which is really the group that we're focused on here at the Health Connector, changes to how they purchase their health insurance in Massachusetts, there are a couple of changes in sources of coverage. So for the subsidized set, there's some changes to the Children's Medical Security Plan, as well as the DUA, Division of Unemployment Assistance, sources of coverage. So before ACA implementation, folks could get subsidized coverage through the Children's Medical Security Plan. This is still true, actually, after ACA implementation. However, the CMSP will not actually meet minimum essential coverage. So if you have coverage through that, you would actually potentially be subject to a penalty. The Division of Unemployment Assistance Insurance, that one will no longer exist after ACA implementation 1/1/2014. Obviously, the next biggest source of subsidized coverage, Mass Health, clearly exists both before and after. We'll talk through some of the differences in who's eligible for that, and some of the population that is currently with the Health Connector will be going to Mass Health, and there's some movement and transition there. And then for unsubsidized coverage, there are really three sources. There's obviously the Health Connector. There are various intermediaries other than the Health Connector. And then there's additionally directly from carriers. So individuals and small businesses can go directly to a carrier like Blue Cross Blue Shield or Harvard Pilgrim or NHP and just purchase their coverage there. So kind of diving in a little bit on the changes to subsidy eligibility on the next slide. There's a lot of changes here, and it can be a little bit confusing to keep track of them. So we wanted to sort of split out, at least for the population that's in the Health Connector and in Mass Health, what this looks like. So if you kind of start at the bottom of this chart here in the blue section, individuals and families with incomes less than 133% of the federal poverty level are now eligible for Mass Health. So you see them, they are in that blue box, Mass Health Standard, Mass Health Care Plus. In the yellow box that's just surrounding that, you see individuals and families that are under 300% of the federal poverty level. These were typically people who were in Commonwealth care previously. It now includes the lawfully present ages 21 plus, the A-list population, all the way down to 0%. Everyone else in that group should be above 133% and below 300%, because those folks who are not A-list, who are under 133%, would be in Medicaid. For the people who are under 300% FPL, who were previously in Commonwealth care plans, they'll now be in what we call connector care plans, which incorporate, as I think you probably already know, cost-sharing reductions, premium tax credits, and additional state subsidies. These plans look very much like Commonwealth care looks today. So in terms of the amount of cost-sharing and also the enrollee premium contribution and requirements, this is what you are probably used to from ComCare. And finally, one big change under the ACA is between 300 and 400% of the federal poverty level. Folks are now eligible to receive federal premium tax credits there. So these people typically before ACA implementation would have received no subsidy. Now they can purchase a QHP on the Health Connector and receive a premium tax credit. So turning to the next slide, looking at some of the changes to Mass Health eligibility, and certainly the folks from Mass Health in the room should feel free to jump in and help me out here if I lead anyone astray. It's not my necessarily biggest area of expertise, but we'll just talk through here. As you know, I'm sure, no doubt, the population for Mass Health really has expanded as a result of the ACA, and at the highest level, as we talked about on the previous slide, most people who are childless adults who are citizens and qualified aliens between 21 and 64 with income under 133% FPL are now in Mass Health, so that's a fairly large change from before. I'm sort of at the bottom of the slide, and I'm only calling that out because we previously talked about that on the slide before. Then going through just sort of the other big change, young adults aged 19 to 20 with incomes under 150% were not eligible for Mass Health previously and now will be under the ACA passage. All of the other categories that you see on this slide were eligible before the ACA and continue to be eligible. So that's children 0 to 18 under 300% FPL, pregnant women under 200% FPL, people with breast or cervical cancer under 250% FPL, and then disabled children and adults with higher incomes. As I'm sure you can appreciate, it's a real challenge to get people to sort of move between different sources of coverage. And so here at the Health Connector, we've been working obviously very closely with Mass Health to make sure that we minimize as much as we can any gaps in coverage for people who are transitioning between Mass Health and the Health Connector, or between other sort of subsidized programs and Mass Health or the Health Connector. So moving on to the next slide, looking at some of the non-group and small group market changes to the way plans are actually sold. So there's a couple of things here that are worth understanding, and you probably are familiar with many of these concepts, but I'll just talk through them. So first of all, actuarial value, or what we usually call AV, and metallic tiers. So AV is basically, it's pretty simple, although it sounds not so simple, but it's basically just a percentage of the total average cost for covered benefits that a plan will cover. So the way to think about this most simply is that if you have a plan with 60% AV, on average, that plan is going to cover 60% of all of the costs for the covered benefits that are covered by that health plan that are incurred by an individual or family. So basically, if you have a plan with 90% AV, or in the case of most of the connector